registered? Shalin?
Ma'am, so far 57 has joined, ma'am.
57.
Yes, ma'am.
Okay.
So, ma'am, we are on live, ma'am. We are starting the session, ma'am.
Yes.
Yeah. So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar, that is TNFOG Marathon CME on Fibroid. I welcome all the participants and I request them to post their queries in the chat box so that we can have discussion at the end of every presentation. And now I take this time to introduce our Secretary of TNFOG, Professor Dr. Sambat Kumari, ma'am. Madam is currently the Chief and HOD, Muthukumar Medical College and Research Institute, Chennai. Madam is the FOGSI Vice President-elect 2022, Chairperson, FOGSI Adolescent Health Committee 2016-18, and Deputy Director and Professor, retired Institute of Obstetrics and Gynecology, Madras Medical College, President, Board of Studies, OGTN, Dr. MGR Medical University 2015-19. Member Board of Studies, OG Meenakshi Medical University, and ICOG Governing Council member 2020. So, Madam has also received various awards to her credit, like IMA Doctors Day Award from IMA TN State Branch, and FOGSI Durusha Distinguished Community Service Award, and FOGSI Mr. N.A. Pandit and Mr. Shailaja Pandit Women's Empowerment Award, and Karmaveer Chakra 15 National Award for Adolescent Activities from ICO NGO. And Madam has also authored chapters in FOGSI textbooks and FOGSI Focus and newsletters. So with this short introduction, I welcome you, ma'am, and I hand over the session to you for further proceedings, ma'am. Thank you, ma'am.
Thank you, Dr. Stalin. First of all, I welcome Dr. Atul Munshi sir and all of our faculties and delegates for the TNFOG CME. The TNFOG is the Tamil Nadu Federation of Obstetrics and Gynecology. We have almost 18 societies in the Tamil Nadu. So we combined the 18 societies, we have started the federation. And this Marathon CME, we are conducting every month on the second Friday. Why it is called Marathon is, every month we have two youth speakers, Yuva speakers. And we have the same judges, two judges, and we have decided to give the prizes for the winners in the Marathon CME for 1 and 2, 3. And in each sessions, we have some questions. At the end of the session, we will have one question. And the delegate has to answer that in the polling manner. And for that also, we are giving the prizes. And this is going on continuously every second Friday. Every month, it is a Marathon CME from 4:30 to 6. And I thank the Shield for continuous marathon support. Now, today's coordinator is our Dr. Rajeshri. Dr. Rajeshri is one of our active EC member of our society, Obstetrics and Gynecological Society of Southern India. She is a consultant in Cloud9 Hospital, and the area of her special interest is high-risk pregnancy. And she has contributed to the book on management of the labor, 3rd edition. Back to Dr. Rajeshri.
Good evening to all. I now invite all the dignitaries to join us for the inauguration with the Tamil Varthu and the lamp lighting. Can we have the Tamil Varthu, please? We will start with the lighting of the lamp. Thank you. Can I now have slide of Anjalakshi Madam? I welcome Anjalakshi Madam. She's a founder president, Tamil Nadu Federation of Obstetrics and Gynecology. She's the past president of OXI. She's a governing council member, DIPSI. She's a PhD in pregnancy diabetology from Tamil Nadu Dr. MGR Medical University. She's a retired professor obstetric and gynecology from Madras Medical College, and she is presently working as professor HOD of obstetric department, Mata Medical College. She's presented several papers in national and international conferences, and her original work on single test procedure for the diagnosis of DGDM followed in guideline of government India. I now welcome you, madam.
Thank
to
you,
introduce
Rajashri.
the chief guest. Yes, ma'am. Thank you, madam.
Yeah. Pleasant evening to all of you. Respected chief guest, Dr. Atul Praful Munshi, office bearers of and the EC members of TNFOG, dear Dr. Parikshit Thanks, and my beloved chairperson, speakers, moderators, and panelists, and my dear delegates. Today, we are here for the Marathon CME of the August month on fibroid uterus. It is the most important common benign tumor of the uterus and commonly seen during the reproductive life and has many myths and challenges. And for this CME, we have our chief guest, Dr. Atul. He is the ex-professor, GCS NHL Medical College, Ahmedabad, President IMS 2010, Chairperson ICOG 2014, Senior Vice President FOGP 2007, Chairperson Age Committee FOGP 2002 to 2007, President Ahmedabad OB-GYN Society 1995, and IMS representative to International Menopausal Society, Convener Academic Council ICOG 2015 to 2017, and FOGP representative to SAFOG 2016 to 2017. He is on editorial board, Pediatric, On-Call, Journal, and Journal of Midlife Health. Sir, I welcome you for this Marathon CME, sir. And I also welcome Dr. Parikshit Thanks, who is going to moderate the panel. Can I have the slide of Dr. Parikshit?
Madam.
Okay. And I welcome all chairpersons, speakers, panelists, and delegates for this wonderful CME. And I request our chief guest, Dr. Atul, to release the newsletter for the month of the August. With this, I thank and Jai Hind. Thank you. Sir, Atul, sir.
Haji. Thank you, madam, for kind words.
And release the newsletter, sir.
Thank you for your kind words.
Yes.
A good initiative by Tamil Nadu Federation of Obstetrics and Gynecology. Every month you are doing this. It's a very marathon task itself. Dr. Anjana Lakshmi, Dr. Sampath Kumari, and Dr. Vijaya Lakshmi. I'm thankful to all of you for involving me in this academic activity. I had a very fond memories of Tamil Nadu. Whenever I come, I have always come out with good memories of it. All along, there is an atmosphere of sports. Olympic is just over. Indeed, it has done the best performance for India this year. Other well-known sport is marathon. And your name is also apt. When we talk about marathon in gynecology, we think about PCOD, we think about endometriosis, and we think about fibroid. Today, you have chosen the word fibroid. It is always a hot topic for discussion, modalities of treatment and outcome. Fibroid is always a hot topic whenever you think about anything of gynecology. Whenever, how to remove it, when to remove it. Operation, laparoscopy or open. In laparoscopy also, whether morcellation by open technique or by closed technique or in the thing. Bag morcellation is always a debate. Today I've seen the whole program. There's a galaxy of speaker for detailed discussion on the subject and then a case-based discussion by none other than Dr. Parikshit Thanks, master of webinar. I congratulate Dr. Sampath Kumari also because she's always there on the web. Whenever you open any of the program, she's always there somewhere or other for president-elect. I'm sure it will be a field of marathon, let the end. Marathon run will be good for the people who go through all this, and they will come out with a winner. They will be winner as far as knowledge of fibroid is concerned. I wish best of luck to this, and not only to this, to ongoing program of Tamil Nadu Federation. Thank you very much.
So thank you, sir. Thank you, sir. I request you to release a newsletter, sir, for the month of
Sir, I
August.
have been to Ahmedabad for one of the CMEs with Dr. Rekha.
Yes.
So we had a good experience. Yes, now we can release the newsletter, sir. Thank you so much.
Two pages for the.
Dr. Stalin, you can send few pages. Yes. Every month on the theme of the topic, we release the newsletter, sir, with the upgrade, with the upcoming programs and everything. Yes, Stalin.
This will going to be like a handbook to the postgraduates.
Is it available on email?
Yes, sir. It is a e-newsletter. I will send by mail also, and it is available on our TNFOG website.
Okay, that will collect because it's a very nice collection.
Yes, sir. Still, I remember the work done by you as a chairperson in ICOG. I was the governing council member. Fantastic with all programs. Thank you. Thank you.
Thank you.
Thank you, sir.
Thank you so much, sir. Thank you. We will now move on to the next session. Can I have the slides, please, of Dr. Nidhi Sharma? Welcome, Dr. Nidhi Sharma. She's Professor of Obstetrics and Gynecology at Savitha University. She's Fellow of Indian College of Obstetrics and Gynecology, Fellow of Assisted Reproductive Techniques. She's a PhD degree in Obstetrics and Gynecology from Savitha University. And she has 100 index national and international publication and has authored several chapters in textbook and been a member of teaching faculty for undergraduates, postgraduates, and PhD for 14 years. Editor of 2 books published in London, Innovations in Assisted Reproductive Technology and Prediction of Fetal-Maternal Syndrome of Preeclampsia. Next slide, please. Vijayalakshmi Kandasamy, doctor. I welcome you, Dr. Vijayalakshmi. She's a professor, Department of OBG, Chettinad Hospital and Research Institute. She has 16 years of teaching experience for both UG and PG. She's mentored several batches of students. She's also an ex-CC member of OXY, and her areas of interest are high-risk obstetrics and adolescent gynecology, infertility, and gynae endoscopy. I now request both of you to take over the session. To please invite the speakers.
Thank you,
Madam. Yes, ma'am. Thank you,
madam.
Good evening, all. Am I audible?
Yes. Yes, madam.
Yeah. First, we'd like to welcome Dr. Divya Ranjit.
Dr. Vijayalakshmi, you tell the whatever the guidelines for this then you can start that.
Sure. As Madam was saying, this marathon CME, we are having young gynecologists presenting at every CME on the particular topic of the CME. And as this is focusing on fibroids, we will be having Dr. Divya Ranjit and Dr. Niranjana Ashokan, the two of them who will be presenting. And Dr. Divya Ranjit will be talking on the pathophysiology of fibroids, and Dr. Niranjana on diagnosis, the modalities. So myself and Dr. Nidhi Sharma, we will be judging them on several criteria. And do you want me to tell about the criteria on which we will be looking at their
No, that is not needed. Timing you can.
Sure. They have a time duration of 10 minutes that they'll have to finish their
12
presentation.
minutes plus 3 Viji.
3 minutes for
presentation, 3 minutes.
3 minutes for the interaction. And now we will move on to our speakers. May we have, the first speaker for today will be Dr. Divya Ranjit, who is a fellow of the reproductive medicine, and she's a consultant gynecologist and infertility specialist, as well as a lab surgeon from Marthandam, deputy director of PPK Hospital. And she's also on the executive committee of the Nagarkoil OBGYN Society. Over to you, Dr. Divya, for your presentation.
Ma'am, it's only 5 minutes, ma'am.
Which one?
5 minutes for Divya.
No. 12 minutes talk
Okay.
and 3 minutes discussion.
Okay. Yeah, I'm timing.
Yes, you have.
We
12
also
minutes
usually
and-
time. Me
Yes.
and my co-judge, we also do the timing.
Oh, you are also timing, ma'am. Okay.
Yeah, we normally do that. Over to you, Dr. Divya.
Yes.
Dr. Divya, you can share your presentation.
Okay, ma'am. Am I audible, ma'am?
Yes.
Audible.
Slides are not shared.
Slides are visible, ma'am.
No,
Not
no,
yet, ma, not yet. We can't see your
not
slide.
visible.
We share the screen.
The technical team, could you please help them?
Ma'am, please open. Yes, ma'am. You have started sharing.
Is it visible, ma'am?
Yes,
Yes,
ma'am.
yes, but
yes,
you have to
yes.
go to slideshow. Slideshow, you go.
Yeah.
Yes, ma'am.
Is it visible, ma'am?
Yes,
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 yes.
Okay, good evening, everyone. Today I'm going to talk about the pathophysiology of uterine fibroids. Often simply called as myomas, uterine leiomyomas are benign smooth muscle neoplasm that typically originate from the myometrium. Uterine fibroids are the major cause of morbidity in women. Fibroids have variable clinical presentation depending on the size and location. These include pelvic pain, which accounts for 20 to 40% of patients, bleeding of about 30% of patients, and anemia. Fibroids that bleed are more frequently submucous type and extend into the endometrial cavity. Problems related to fibroids include problems with implantation, preterm labor, recurrent loss of pregnancy, obstruction of labor, and urinary incontinence. There is a variable risk of developing fibroids in women depending on race, hormone exposure, age, diet, and other factors. Some factors may be modified and, if altered, have the potential to reduce the impact of fibroid-related morbidity. Grossly, a typical off-white whorl leiomyoma is autonomous form, its surrounding myometrium, because of a thin outer connective tissue layer. This clinically important cleavage plane allows leiomyomas to be easily shelled from the uterus during surgery. Microscopically, leiomyomas are composed of bland spindle smooth muscle cells characterized by elongate, blunt-ended nuclei and tapered eosinophilic cytoplasm. The cells are arranged in interlacing vesicles that intersect at right angles. The interface between the leiomyoma and the adjacent myometrium can be grossly and microscopically differentiated. These tumors are usually more cellular than the surrounding myometrium. Coming to the epidemiology, a number of factors have been linked to the development of fibroids. Some factors are modifiable and may be useful in promoting preventive health care. Numerous risk factors for fibroid development have been described, several of which may be affected by changes in diet and lifestyle. Coming to the fibroid growth rates, fibroids from women more than 45 years of age grew more rapidly in Black women than in white women. White women had a decrease in growth rate with age. Rapid growth was seen more frequently in young white women than in older white women. The frequency of fibroids with rapid growth did not vary with the age in Black women. Fibroid growth rates were faster in women with a single fibroid than in women with multiple fibroids. Coming to the age, fibroids are often diagnosed in older premenopausal women. A woman's age at birth of the last child was inversely related to risk of fibroids. Fibroids have not been described in prepubertal girls. The incidence of fibroids by age 50 was estimated as 70% for white women and 80% for African American or Black women. Fibroids were detected about 10 years earlier in Black women than in white women. Coming to this tabular column, the risk factors for fibroid development have been described. In Black women, usually the urinary 2-hydroxyestrone and 16-alpha-hydroxyestrone metabolite excretion is decreased, and the vitamin D in blood levels is also decreased in Black women, and increase in aromatase is found in blood levels. So this causes increase in estrogen exposure, which in turn causes increased fibroid risk and increased fibroid risk. And the increased early age of menarche is another reason for fibroid incidence. This causes increased estrogen exposure associated with increased cellular proliferation and risk of genetic mutation and expression of progesterone receptors. The increase in progesterone receptors is associated with suppressed apoptosis, which is due to increased B-cell lymphoma 2 expression, transforming growth factor beta expression, and increase in cellular proliferation and increase in extracellular matrix formation. Obesity. Women with increased BMI may have more bioavailable circulating estrogens and androgens. Obesity has been associated with a modest increased risk of fibroids in several, but not all, in several international studies. BMI during adolescence has not to date been associated with an increased risk of fibroids.
One more minute, Divya.
Diet and exercise. Several studies have suggested an association between diet and the development of fibroids.
You are not audible, Divya.
Increased consumption of, am I audible, ma'am?
Yeah.
Increased consumption of red meat and decreased consumption of green vegetables have been associated with an increased risk of fibroids. Citrus fruits had the highest inverse association. And caffeine, increased intake of caffeine, like more than 500 milligram caffeine a day increases the risk of fibroids. Alcohol intake also increases the risk of fibroids, and smoking historically associated with the decreased risk of fibroid formation. Early age of menarche is another reason due to increased estrogen exposure, and menopause, there is a decreased incidence of fibroids. Coming to parity, pregnancy has been associated with a 5-fold reduction in the incidence of fibroids. OCP's use also decreases the rate of fibroid growth. Hormone replacement therapy in case of postmenopausal patients increases the rate of fibroids. Tamoxifen, only animal studies are available, and xenoestrogens like soy and flax contain the greatest quantities of these compounds, and these compounds decrease the incidence of fibroid growth. And coming to the theories of fibroid growth, there are many theories related to the fibroid growth. Coming to the initiation, while male genetic events have been described in fibroids, the initiating events are not clear. Hypothesis initiating events include chronic exposure to high levels of estrogen and progesterone leading to increased cellular proliferation and an associated introduction of genetic mutations through errors during gene copying. Increased levels of estrogen receptors are found in fibroids and may be a contributing factor. Genetic findings in fibroids similar to those found in scars have led to the injury hypothesis. Here, vasoconstrictive factors secreted during menses are thought to lead to ischemia and local uterine muscle injury. Another potential initiating factor may be activation of genes associated with the familial or inherited occurrence of fibroids.
Divya, please conclude, ma.
Ma'am, few more slides are there, ma'am. Can I?
7 minutes over. You ask the judges.
Continue.
Yeah, please continue.
The promotion and progression, and estrogen is more generally accepted as the principal promoter of fibroid growth. Several observations suggest estrogens contribute to fibroid development and growth. Estrogen binds to estrogen receptor alpha, activating transcript of multiple genes, including the progesterone receptor. And coming to this slide, increased expression of estrogen receptors, progesterone A and progesterone 3 receptors, insulin growth factor 1, 2, and insulin growth factor 2 receptors, epidermal growth factor, transforming growth factor beta, and basic fibroblast growth factor is increased in fibroids, and this causes increased leiomyoma cell proliferation, decreased apoptosis, and increased expression in fibroid extracellular matrix, which causes greater volume of matrix and increased expression of basic fibroblastic FGF, decorin, transforming growth factor beta 3, and this results in increased angiogenesis and increased extracellular matrix formation. And coming to the hormone receptors, estrogen and progesterone receptors appear to contribute to fibroid growth. Increased expression of estrogen receptor and progesterone receptor A and B are reported in fibroids compared to normal uterine muscle. Fibroids have increased cellular expression of the basic fibroblast factor receptor, and fibroids that bleed have higher expression of the type 1 BFGF receptor. coming to the genetic findings, several types of familial expression of fibroids have been observed. This expression of fibroids has been found in women with Reed syndrome, Danon-Sonona syndrome, and Alport syndrome. And the cytogenetics, about 60% of fibroids have normal cytogenetic studies. Patients with cytogenetic abnormalities more frequently have a 12:14 translocation, a trisomy 12, a 6:10 translocation, or deletions of chromosome 3 and 7. The most common finding is the 12:14 translocation occurring in about 20% of women with cytogenetic abnormalities. And this slide shows the MED12 mutation, that's the mediator of RNA polymerase 2 transcription subunit 12 homolog mutation, which causes the incidence of fibroids. The MED12 mutations are frequently found in leiomyoma. MED12 mutations are found in fibroid cells and not normal uterine stem cells. It is found in fibroid stem cells and not in normal uterine stem cells. This MED12 binds to estrogen receptors alpha and beta, which increases cellular transcription, increases progesterone-related responses. Like an active wingless beta catenin signaling in normal uterine smooth muscle, which this signaling causes increased cellular proliferation and increased TGF-B3 expression. High mobility group at HOOK2, HMG-A2. This HMG-A2 expression is found in a smaller subset of leiomyomas. Mutations in this HMG-A2 are associated with larger fibroids and solitary fibroids. And coming to the conclusion, risk factors for fibroids may achieve significance through their contribution to either the promotion phases of tumorigenesis, although their impact often appears related to their effect upon estrogen involved. Two of the more consistent risk factors that have been identified are age and the African American ethnicity, that is the Black women. Karyotypic abnormalities have been identified in approximately 40% of surgically removed uterine leiomyomas. The most common of these are the translocation 12:4 and the deletion of 7q. Estrogen and progesterone appears to be the promoters of fibroid growth acting in concert. Thus, estrogen upregulate both the estrogen receptor and progesterone receptors during the follicular phase, followed by progesterone-induced mitogenesis during the luteal phase. The levels of several growth factors and their receptors are increased in fibroids. TGF-B3 and BFGF may be especially important in the pathogenesis of these tumors in view of their combined mitogenic effect and promotion of extracellular matrix production. Thank you.
Thank you, Dr. Divya. Okay, I have one question for you. Okay, so initially you said about urinary incontinence, fibroid, one of your initial slides. So which is more common, incontinence or retention urine?
Retention of urine.
Yeah. But instead of retention urine, you had put incontinence, no?
But, retention is common.
Ma'am, Vijayalakshmi, ma'am, you want to ask?
Yeah. Divya, actually, yes, this was a very extensive presentation, especially for the genetic aspects of the fibroids and also the mutations which you were talking about. Is there anything like hereditary leiomyomas? Is there a condition like that? Are you aware?
Yes, ma'am. Hereditary reason also causes this myoma formation, like Reed syndrome, Alport syndrome, and the banana syndrome. This causes gene mutations and which causes the incidence of fibroids hereditally.
Yeah.
Okay.
Thank you, Dr. Divya. Madam? Maybe madam?
Yes, ma'am. Dr. Nirajana Asokan, she is done her master's in obstetrics and gynecology, DNB, and she has also completed member of Royal College of Obstetrics and Gynecology examination. She is currently doing her fellowship in gynecological endoscopy. She is a member of Royal College of Obstetrics and Gynecology. She has presented papers at Yuba Foxy and AICOG. She also did a capsule presentation in AICOG in Bangalore. She has been the winner of the prestigious Oxy Quiz 2017. She was awarded as a Best Paper South Zone Yuba Foxy 2016 in Madurai. Dr. Niranjana had won Dr. Amrendra Nath Dan Prize at AICOG 2019 Bangalore Ma'am, please, we welcome you. Please enlighten us.
Thank you for that kind introduction, ma'am. Okay. Very good evening to one and all present. First, at the outset, I'd like to thank Dr. Anjalakshi ma'am and Team TNFOG for giving me an opportunity to be a part of this wonderful conference. The topic of my session is diagnosis of fibroids. We all know fibroid is a common condition which we are going to encounter in our daily gynecological OPD. We know it's going to be seen in about 50 to 80% of the women by the time a woman reaches 50 years. And we also know fibroids can be present uterine or extrauterine. And FIGO has classified the fibroids into type 0 to type 7, with each fibroid giving a different clinical picture and requiring different investigative modalities. Like with any condition, diagnosis can be done either by routine history examination, imaging techniques, invasive procedures, or laboratory tests. So I'd be explaining about all these methods of diagnostic techniques available for a fibroid in my presentation. There can be a lot of technological advances. Ultrasound can become available everywhere, very easily, cost effective, but that doesn't mean we can forget our basic history and examination. So history and examination gives us a suspicion of the diagnosis and helps us to point the women in a correct diagnostic pathway. So that said, history becomes very important, and history can be taken in terms of menstrual complaints, pressure effects on the urinary or bowel, or pain complaints. History can also help us to find the site of the fibroid. A submucous fibroid can present as menorrhagia or an infertility. Intramural fibroid can present with dysmenorrhea or heavy menstrual bleeding. A subserous fibroid can present with pressure effects on the bladder causing urinary retention, or even on the bowel causing constipation. Cervical fibroid can lead to a urinary retention. Although these are the common complaints we encounter, it is to be remembered that about 50% of fibroids present asymptomatic. The common reason a woman comes to us is bleeding, heavy menstrual bleeding. And that is one common diagnosis that helps us to find a fibroid. And the second common diagnosis we encounter is infertility. Fibroids might be seen only in 5 to 10% of infertile women, but infertility goes for extensive evaluation and helps us to pick up the fibroids that are even asymptomatic. Once the history is done, we move on to the examination. A simple abdominal examination can give us a lot of findings. A fibroid can be small, single, multiple, or huge, occupying the entire abdomen. An abdominal examination is going to show us a midline mass coming out of the pelvis, a lower border that is not palpable in some cases, like submucous fibroid, with the surface can be smooth or irregular in multiple fibroids. A perspeculum examination can show a fibroid polyp protruding through the os, or a distended cervix in case of a cervical fibroid. A pervaginal examination is going to show us an enlarged uterus with transmitted mobility, which transmits the mobility of the cervix to the fibroid. So once we do the history and examination, we have a suspicion of fibroid. The next thing we order is a lab investigation. And the important test we order here is a complete blood count, because fibroid presents with menorrhagia, which can lead on to anemia. So incidental women may not give us a history of menorrhagia, but when we find a low hemoglobin and we probe her further, we can pick out a history of menorrhagia and identify a fibroid. CA-125 can be elevated in fibroid, but it can also be elevated in other conditions, so the significance is lost. The other blood test of significance is LDH and the LDH isoenzyme. The importance of this test is the pre-op sarcoma diagnosis. When there's an increase in the LDH or the LDH isoenzymes 3 and 5 level, there is a risk of sarcoma anticipated, and the surgery has to be planned accordingly. A UMG index cutoff has been, that is a ratio between LDH3 and LDH1, has been set as a cutoff of 29, which had a 91% specificity in identifying a sarcoma. However, we need to remember that sarcoma cannot be predicted completely by any pre-op test, and it's only a pathological confirmation. Once we order the investigation, the next thing we go to is an ultrasound. Ultrasound uses the principle of sound waves, which hits on the organ, received back by the transducer, amplified to give an image on the monitor. It can be done either transabdominally or transvaginally. The purpose of a vaginal scan is that it has a better resolution for pelvic pathology because we see it near the pelvis. It can be used in case of inadequately filled bladder, in a woman who's obese, where there's large bowel shadows. But a large fundal fibroid or subserosal fibroid can be better picked up by a transabdominal scan. Combining both these modalities can improve the sensitivity of the pickup of the fibroid. So this this study in 2016 has shown that transvaginal ultrasound is more sensitive and more specific than a transabdominal ultrasound in picking up AUB caused by fibroids. So when you do an ultrasound, what are you going to look for? So you need to know what you're looking for. Only then you can identify a fibroid, because ultrasound is an operator-dependent modality. Fibroid is a growth of the normal myometrium. It's going to have a difference from the normal myometrium, compress the myometrium to form a pseudocapsule and appear as a well-defined solid hypoechoic mass with a pseudocapsule. A submucosal fibroid can be seen on a transvaginal scan distending the cavity. However, a fibroid is not going to present only as a normal fibroid. It's going to undergo various degenerations like the calcific degeneration, hyaline degeneration, cystic degeneration. Only if we are aware of the various presentations that it can cause, like hyperechogenicity or anechogenicity along with the degeneration, we can pick up the fibroid and give the proper diagnosis. Otherwise, we can find a cystic degenerated myoma and report it as an ovarian cyst, which grossly alters the treatment protocol. So that moves on to the differential diagnosis. And adenomyosis can be confused with a fibroid. So what do we look for in an adenomyosis is, adenomyosis is a globular enlargement with cystic spaces in the myometrium with obscured endometrial myometrial junction. Endometrial polyp can also be confused, which appears as a homogeneous hyperechogenic mass. Adnexal masses can be confused. So that's where, with the skill of the operator, the diagnosis is going to be easier. But in the initial phase, when the skill of the operator is going to be a little less, we go for additional investigations. A color Doppler. Color Doppler helps us to identify a fibroid because fibroids have circumferential vascularity. The vessels are arranged around the periphery, forming a ring of fire appearance, whereas adenomyosis can have a scattered vascularity. So this is a finding that can help us to find a fibroid. Saline infusion sonography. Here, we thread a catheter into the uterine cavity, distend the lumen with water. So in a distended lumen, we go with the ultrasound probe and see the submucosal fibroid or an endometrial polyp that is better visualized in the distended cavity. But when we do a hysterosonography, we should advise the patient that she can experience cramps, dizziness because of cervical irritation, and it is preferably done between day 5 to day 9 of the cycle. 3D ultrasound. Here we image the uterus in all planes, the coronal, sagittal, transverse plane, and this multiplanar image helps us to recreate the uterine architecture. So even if you feel that you are less skilled, a 3D ultrasound is going to give you a complete picture. So that will help you to have a suspicion of fibroid. And when you have the suspicion, and you can even go for additional tests to confirm your diagnosis. The problem with the 3D ultrasound is when there's multiple myoma, the image is going to be distorted. And this it cannot be a proper image cannot be obtained at times. There's 3D power Doppler. That is, a fibroid is going to have a low impedance in the blood flow. So when you use a 3D power Doppler, you have a difference in the blood flow between the fibroid, sarcomatous tissue, fibroid, and the normal myometrium. And so it can be used as a virtual biopsy to rule out malignant potentials. 3D saline infusion sonography can be done rather than a 2D saline infusion sonography to have a better diagnosis. CT is another advancement, but it's not of much use in fibroid because a normal fibroid and a healthy myometrium do not have difference in their signal intensities. However, it's useful for a calcified or a necrotic myoma. MRI. This is one very big advancement which we are using very often in our diagnosis of fibroid. It is not routinely required, but the advantage of a MRI is that it gives us a very detailed report and it is very useful in preoperative planning. So fibroids tend to have a low signal, well-defined borders. Where the MRI becomes significant is differentiating between a fibroid and a sarcoma, which I will deal with in the later slides. So those are the imaging modalities available. With these modalities, what we do is called a myoma mapping. So before going in for a surgery, we find out how many myomas are there. What are the additional features? Like if you're going to pick up a hydroureteronephrosis on an ultrasound or an MRI, you'd be better prepared. You trace the ureter, you'll go for additional investigation, have a urologist if required. You can find bowel compression. So these additional findings helps us to prepare our surgery. Likewise, with myoma mapping, we go the exact number, size of the myoma, and we can plan our incision and anticipate complications. Leiomyosarcoma. Although the incidence is less, we need to be better prepared, because when we go for laparoscopic surgery, we are going to use power morcellation. And when we go for power morcellation in a sarcoma, we will end up in spreading the disease. That's where we use pre-op scoring. So this study has shown that using a LDH and LDH isoenzyme levels with ultrasound criteria of vascularity, echo texture, cystic degeneration with a cutoff score of 18, and women with high risk are advised for MRI to find out intratumoral hemorrhage, alterations in the T2 signals, to find out either they have a 3 conventional criteria or a 1 malignant criteria. We suspect them a risk of leiomyosarcoma and plan accordingly. A PET-CT can be done. PET-CT goes on the principle of FDG uptake. But the problem here is fibroid cells are proliferative and estrogen dependent. Sometimes even a normal fibroid can show an increased pickup. That's why PET-CT is more significant for a negative predictive value rather than a complete confirmation of leiomyosarcoma. Another modality available is the dynamic contrast MRI. What we do here is that we use a gadolinium contrast, take a pre-contrast CTG, immediate post-contrast MRI, and follow it serially to find the time signal intensity curve. So the rate of clearance is monitored in a graph, and this graph helps us to find out if it's a malignant or a benign pathology. So these are the various imaging modalities that are available with us. Another study has shown that contrast enhanced MRI has a better accuracy in diagnosing benign and malignant leiomyoma. So with all these modalities, if you cannot find a diagnosis, the next option you go for is invasive. Hysteroscopy, you go in, see the cavity. In infertile women, we cannot go in and treat her for infertility without ruling out fibroid. If in doubt, if your imaging is not confirmatory, we can always go for hysteroscopy, visualize the cavity directly, see if there is any submucous fibroid, because a small fibroid can only be seen as an alteration in the uterine contour on ultrasound. And the last option, laparoscopy, although it's not a first-line diagnostic tool, in special conditions when you cannot confirm your differential diagnosis, laparoscopy can be used as a diagnostic tool to find the fibroid. So those were about the various imaging techniques available. But what technique you use for which patient is a skill that we acquire with practice. In an adolescent female, we cannot go and say that you need to go for a hysteroscopy. There, history and imaging and ultrasound gains precedence. Whereas in infertility, we cannot just say that you're fine with a half ultrasound report. In that case, if she's going in for IVF, we go for a hysteroscopy, see if her cavity is normal before going in for a complete fertility treatment. We need to remember that clinical examination is most important and ultrasound is our go-to tool. If the ultrasound can be done by the gynecologist ourselves, we have a better view of the fibroid, better pre-op planning, and this helps us to give a better outcome for the patient. So I would like to conclude saying that all the diagnostic techniques are available. It's up to us to find the best choice, use minimal resources to give the better diagnosis so the patient can have a better quality of life. Thank you.
Thanks, Dr. Niranjana. That was a very exhaustive presentation. Okay, I have a question for you. Okay, what is the preoperative sarcoma score or PRESS score?
Preoperative sarcoma PRESS score, we use a criteria of 0, 1, 2 points, ma'am. Yes. There's age, cytological finding, MRI finding, LDH values. We use these. Total points of 7 is used. This can be used to diagnose the risk of sarcoma prior to the surgery.
Okay, so more than 3 is possible. Total point is 7 in that PRESS score. Okay, another question, if you don't mind. What is the role of CT angio in deciding about the fibroid vascularity?
CT angio for uterine artery embolization, maybe we can use an angiography to go preoperatively and use it.
Yes. We do CT angio also in our setup because it is embolization is possible.
Yes.
Thank you.
You've talked extensively, Niranjana. Is there any role for IVU in a patient with the fibroids? If so, when would you want to do it?
If there's a huge fibroid, subserous fibroid, or intramural fibroid occupying the entire cavity, it tends to compress the ureter, alters the course of the ureter. So even if you are going
what type of fibroids mostly we're looking at?
Sorry, ma'am?
What are the types of fibroids which probably might cause that?
Most commonly subserous. So it can alter the course of the ureter. So even if you are going to operate within the capsule, at times an IVU helps us to diagnose the course of the ureter preoperatively trace the ureter during the surgery following the course, and prevent the ureteric injury, inadvertent ureteric injury during a myomectomy.
Thank you.
If you are okay with this, one more small question can you ask? What is the role of hycosite? You said imaging modalities, no? Hycosite.
Contrast.
Yeah, what is the role of hycosite?
Hycosite, we can use it to find most of the better in pickups, submucosal fibroids, it helps us in picking up the submucosal fibroids better, ma'am.
What is the advantage of hycosite over HSG?
Not very sure, ma'am.
It doesn't have a radiation exposure, no? And the contrast is not iodinated, so it is more safer and less painful. Thank you.
Thank you, Niranjana. That's very extensive and nice presentation. Over to Dr. Rajshri.
Yes, ma'am. I thank the judges and also the speakers. Ma'am, Sampath ma'am.
Yes, we thank Dr. Nidhi Sharma, Dr. Vijay Lakshmi, who is always there on every second Friday. We catch them. And the speakers, Dr. Divya and Dr. Niranjana. Thank you. We will go to the next session. Thank you, Dr. Nidhi and Dr. Vijay.
Ma'am, you're going to project questions, ma'am?
Yes, with the Chitrakala. Yes, delegates, please answer the questions that is seen that will be projected in the screen. Rajeshri, you can read the question.
Yes, ma'am.
Yes, Rajeshri.
Hysterosonography is better for fibroid of intramural fibroid, subserous fibroid, submucous fibroid, or cervical fibroid. Hysterosonography is better for which of these fibroids?
Yes, Chitrakala.
Share the results.
That is her results is there. Then she will tell the answers. Chitrakala, submucous fibroid 89%, subserous 4. You'll see the answer later. Yes, Rajshri, we can go to the next section.
Thank you, Sampath ma'am.
Dr. Chitrakala will project the answer. Who is first? She will project. Thank you, delegates, for answering. Chitrakala, the polling and Nirthidama. Polling.
Ma'am, done, ma'am. Please close.
Okay, screen la iruke.
Ma'am, neenga close pannidunga, ma'am.
Na close pannaliya?
Yes, ma'am.
Okay. Yes, Rajshri.
Can we move on to the next? Can I have the slide, please? The next session, we'll have the welcome to chairpersons. The first chairperson will be Dr. Kamal Selvi Sedupati. She's done her MBBS from Coimbatore Medical College and MD from Madras Medical College. She's presently consultant at CK Hospital, Erode. Her areas of interest are infertility and reproductive medicine, and she's presented an eye poster in RCOG 2021 titled Isthmosil Diagnosis and Repair, a Case Report. Welcome you, madam. Can we have the next slide, please? Dr. Saraswati, Dr. K. Saraswati, she's a former director, Institute of Obstetrics and Gynecology, currently head of the Department of Obstetrics and Gynecology, Sri Balaji Medical College and Hospital. She's a past president of OXY and she's state level trainer for manual vacuum aspiration program of OXY. She's been a UG and PG teacher and examiner for more than 25 years and she has had the President James Saheli International Award. We welcome you, Saraswati Madam. Can I have the next slide, please? Dr. C.R. Anuradha, she's done her undergraduation and post-graduation from Stanley Medical College, and she's currently head of the Department of Obstetrics and Gynecology, Chettinad Medical College and Research Institute. She has received a University Gold Medal during her final year and the Best Doctoral Award from the Department Medical College. I invite the judges and I request you to take over the session, introduce the speakers.
Thank you, Rajshri ma'am. Am I audible?
Yes, ma'am, you are audible.
Yes.
Hello, Raj.
I would like to take this occasion to thank Tamil Nadu Federation of Obs Gynae for giving me this opportunity to chair this session, and especially Sampath ma'am and Anjalakshmi ma'am. My respects to you. and Saraswati ma'am, my medical superintendent at Egmore Institute. And let us move on to the topic. And the topic, first speaker, I'm going to introduce the first speaker, the topic being infertility and fibroid. Fibroids, as you know, is present in about 7 to 10% of the infertile population, and it is almost indicated as a sole cause in 2 to 3% of the population. Let us hear from Selvapriya, Dr. Selvapriya Saravanan. She is an MD-OG, FICOG, DRM from Kiel University, and she has a fellow in fetal medicine from MGR University and a fellow in obstetric scan from Mediscan in Herkiti. She is a director of Aspiring Fertility Fetocare Fetogene Center, and she is clinical director at NDJH Gift Fertility and Fetal Medicine Center. She is secretary, Nagargoil OBGYN Society 2021-2023. And over to you, ma'am.
Thank you, madam. Can I start sharing my screen? Yeah, this one.
No.
Go to the first slide. What? Go to the first slide. Go to the first slide. Just a minute. Close it and open it.
Ma'am, please click slideshow, ma'am. Slideshow.
I'm not getting the slideshow. Just a minute. Which one?
Next. Yes, ma'am. Please click that, ma'am.
Yeah.
Yeah. Yes, ma'am.
Sorry for the delay. And because I have just 15 minutes, I know it's a vast topic and an area where all of us can give our inputs, because something which we are seeing in our daily practice. And thank you to all my chairpersons and the team, TNFOG, Sampath madam, Anjalakshmi madam, thank you so much. I know it's 15 minutes. Nethe Rajashri madam soltanga not to exceed time, so I'm going to rush. So I will start with a conventional slide which says that fibroids are common in the reproductive age in 20 to 30%, and incidence of fibroids in infertile women is around 1 to 2.4%. So the clinical presentation, it's usually asymptomatic. And when there are symptoms, it's related to the location, size, number, and excessive menstrual loss, pain, infertility, and especially with submucous fibroids, pregnancy complication, and urinary changes. So when we talk about fibroids and infertility, we have also seen, I know in our practice, we have seen like women with 10 centimeters fibroid conceiving without any issues and even delivering normally, and leaving us to a confusion whether we need to remove the fibroid or not during pregnancy. And we've also seen 2 or 3 centimeters fibroid sitting in abnormal locations and giving long period of infertility. So mostly it is depending on the location where it is and how far it is not going to disturb conception and pregnancy. So that it can be tubal occlusion, or it can act like a foreign body, or it can create abnormal vasculature, or it can create altered contractility and endometrial inflammation. That's how myomas and infertility goes. So mechanism of reduced fertility associated with fibroids. This is mainly because of hindered gamete transportation and obstruction of tubal ostia and endocervix, and induced uterine contraction because of prostaglandin release, and implantation failure, which can be because of endometrial changes, atrophy, ulceration, hyperplasia, polyps, and vascular alterations, and all the other complications associated with fibroid not allowing to prolong pregnancy. So as such, the complications, what we are bothered about is not only the conception part, but also spontaneous abortions, premature labor, ectopic, IUGR, abruption, malpresentation, dystocia, and PPH, and this all comes after conception. So when there's an observation of reproductive dysfunction with fibroids, about half of the infertile women with fibroids, they become pregnant after myomectomy. Myomectomy is found to be the most useful whenever you suspect that fibroid is obstructing the women from getting pregnant. And 43% of the women with fibroids who presented in labor had at least 2 years of history of infertility. So fibroids are associated with high rate of overall pregnancy loss of 60%, and myomectomy halves the risk of spontaneous miscarriage. Surgery reduces first and second trimester loss. So we all know how we are diagnosing fibroid, how circumscribed they are, how easy it is to diagnose. And it is extremely important that we have to rule out the exact location, size, and whether the tubes are obstructed, how the endometrial cavity, we all know that. So we all believe in SSG and contrast hysterosonography. The imaging part was beautifully dealt by the previous speaker. And the role of MRI also has to be clearly kept in mind when the fibroid size is on the edge, like not too big, not too small, but the patient is not getting pregnant. So there must be something hidden, and there must be something more than what the ultrasound can contribute in diagnosing the problem the fibroid is creating. And in such cases, MRI, because we've seen that there would have been just a 3 centimeter or 4 centimeter fibroid, and we would think that this is not going to hinder the treatment in any way. We have also proceeded with 1 or 2 IUIs after stimulation, thinking it's just a 3 centimeter, and then they don't conceive. So we advise myomectomy and tell the patients, can you please do a MRI before stepping into that? And then you find the abnormal location of the fibroid, and indirectly it is hindering the path endocervix or disturbing the endometrial cavity. So definitely MRI in certain cases gives more information than the regular ultrasound. So when you do the hysteroscopy, which is the ultimate thing, and all the submucous fibroid and endocervical canal, which can be easily found. Also, we have observed that in case of fibroid uterus, you can also find some altered vascularity and also strictures inside the uterus. There is internal os tightening also in many cases when the fibroid is located mostly in the posterior wall. And the prognostic factors, it's multifactorial in infertility. There is age more than 35, the submucous and intramural fibroids, the fibroids being more, multiple fibroids in different locations, and the volume, if it is less than 100 ml, and the size of fibroids more than 5 and more than 8, all these directly contribute to being the prognostic factors. So also it is more commonly associated with second trimester pregnancy losses and presence of menorrhagia and the duration of infertility, unexplained infertility. All those are the factors which determine the prognosis. 1 minute, sorry, it's getting stuck. Okay, so when we talk about infertility, it's not only about conception, because conceiving in fibroids is mainly a mechanical disturbance. Mechanical disturbance is what creates infertility in fibroid cases. But when we go beyond that, when we are forced to do an IVF on a patient with a small fibroid, the potential effect is because there can be unexplained or sudden onset uterine contractility, and there can be change in the microvasculature, which we are very concerned about, and the aberrant location expression of growth factors with angiogenesis as well as the other regulatory process. So in submucous fibroids and fertility, 5 to 18% of all the fibroid cases, they are the causal factor of infertility. There is low pregnancy and implantation rate in patients, and pregnancy rate is similar to controls following surgery. My slides are half hidden in the screen and I'm missing one part and it's getting stuck. I'm really sorry about that, but hope it's not the same for you all. So these are images of submucous fibroids, and once it's submucous fibroids, in fact, sometimes we are very happy because we clear-cut know that this is the reason for infertility and it's going to be removed, and further we are not going to have any other problem. The trick is with all those silent fibroids, which we think, we get so confused often when we see a 2.5 to 3.5 centimeter fibroid. What to say this patient? She's come with 2 to 3 years of infertility. Should I tell her that this 2.5 to 3.5 centimeter fibroid is affecting her? Or should I ask her weight? Because nowadays, patients Google everything and come. They're coming, they come to me with reports saying, I just have a 3 centimeter fibroid. And I have come to know that I don't need any medications for that, but I've not conceived for 3 years also. It becomes a very tricky situation. You are forced to do all the regular things, like for a regular infertility patient, for at least 3 months before saying that even that 3 centimeter fibroid has to be removed. So what is my slide? It is again, I think, intramural fibroids and fertility. So here we are very happy because most of the time it has no effect. An adverse effect is when the cavity is distorted alone. And when the cavity is not distorted, we are not bothered about it. So only when the size exceeds a particular thing, we are bothered about the intramural fibroids. So does treatment of the intramural fibroid that has not distorted the cavity improve? There is no data. But again, subserous fibroid and infertility, no effect. So that's what I say. When it comes to fibroid and infertility, we have seen 10 centimeter fibroid getting pregnant spontaneously. And again, data which is saying that this doesn't have to be treated, and data saying it has to be treated either. So the treatment will be, if you think and if you are convinced that this fibroid is the reason for infertility, then we go to the treatment options. That is, medically we go for GnRH and selective estrogen receptor modulators, and radiologically we believe in uterine artery embolization, and surgically we have all the options: hysteroscopy, laparoscopy, and laparotomy. And in the medical therapy with the GnRH analogs, the 35 to 65% of reduction in size of the fibroid, and primarily we use it for the pre-operative treatment only, and no significant effect on the intraoperative blood loss. So no effect on the operating time, the difficulty in procedure, and post-operative morbidity. So the current management of fibroids prior to ART does not include GnRH analog treatment. That's what we were able to come. So the medical therapy, the part 2 would be raloxifene, the SERMs. So the low dose for 6 months and maximum effect when used with GnRH, and 70% reduction versus 40% for GnRH analog. And uterine artery embolization, yes, it is gaining a lot of scope in the current time, because already they are coming for treatment for infertility, and we don't want to disturb their hormonal patterns, which would be also an additional challenge. So uterine artery embolization is gaining attention. There is 42% reduction in the volume of the fibroid, and 77 to 86% symptomatic relief is also there. And so this gives an overall satisfaction rate of 91% and amenorrhea of 3% in women under 40. So it should be avoided in women who want to become. Again, we are disturbing the vascularity of the uterus. That is another part. So, and the MRS-FUG, which also I want to talk, because I was closely associated with Mridubhashini madam, and I was in Coimbatore with her, and I've seen her successfully using the MR guided focused ultrasound radiations to shrink the size of fibroid in case of infertile women, because we used to be very skeptical to remove abnormally placed fibroids. So first we used to put them on a round, and that was something which we were really convinced, because I saw it with my eyes. And what is this? Again, I'm not able to see half of my slides. 1 second. It is hiding my presentation, madam. Nothing.
Yeah, Selvapriya, we can see the slide.
I am not able to see. It's hiding in a padi read pannitrukken. And so in patients desiring future pregnancy, the current treatment standard for uterine fibroids is only surgical. How much ever we are going to talk about uterine artery embolization, analogs, SERMs, we are in some way directly or indirectly, we are interfering with the vasculature, we are interfering with the hormonal pattern, and these two are absolutely essential in an infertile woman. So very clearly, all the data, even though we have various modalities of treatment of fibroids, the surgical is the easily accepted one. So the laparoscopic myomectomy here, the numbers are again tricky, but in 6 to 7, it is really helpful, and experienced surgeon is required. There is lower risk of pelvic adhesions and higher risk of recurrence though, and risk of uterine rupture during pregnancy. Hysteroscopic myomectomy is the treatment of choice for submucous fibroids, and comparable, we have very good pregnancy rates, and again, they have risk of adhesions, but they have the better choice. And laparotomic myomectomy, here the large and multiple fibroids where entry into the cavity is expected, and the risk of bleeding and adhesion formation can be easily tackled. And the myomectomy techniques, so we've compared the hysteroscopy, laparoscopy, laparotomy, and the pregnancy rates and the mean pregnancy rates. So we find that almost everything is giving 46, 48, and 46, which we should be happy. So the right modality should be chosen. So this myomectomy myomectomy has risk. Increased uterine rupture risk after laparoscopy. That can be mainly because of inappropriate uterine repair. And we can't even call it as inappropriate uterine repair, because we would have done the best at that time on spot to do everything possible to keep the uterus intact. But in spite of it, it would not be an adequate repair because it's already a damaged part of the uterus and increased energy for hemostasis, and there's a little poor recovery. So does myomectomy as risk again? There is increased risk of uterine rupture after laparoscopy. Adhesion formation is there in any surgery, so nobody is going to leave that, but still. And so the golden questions and decisions it is all mainly dependent on the symptoms and complications, the type of fibroid, the distance from the endometrium, the distortion of the cavity, and the age, the ovarian reserve, and all the other factors related to infertility. And there may be, I love this slide because there may be circumstantial evidence, but the case of fibroids causing infertility remains to be established. Other than mechanical discomfort. So the absence of evidence is not evidence of absence. So when we can collect evidence for both, that fibroid is the reason for infertility, or just the mechanical disturbance caused by the fibroid is the reason for infertility. And so the danger of misinterpreting the differences will do not reach significance at all. So it's such a common tumor which we see in our day-to-day practice, and the fibroids just coming in different ages of a woman, like before marriage, in the reproductive age, post childbirth, everything, the management is different. So even though we have 101 options of dealing fibroids, and especially for the infertility patients, I find that it's very tricky. It's tricky only when you are able to clear cut say this is a mechanical disturbance and it is because of this you are not able to conceive. And rest of the conditions, they are left just aside because still there are stimulations going on with small fibroid uterus. It doesn't disturb the pregnancy much. And the significant health and cost implications is truly remarkable that virtually nothing is known about its causation. There is little evidence as to individualize and optimize the treatment and understanding of clinical outcomes following the treatment. And most of the time it looks rudimentary. So I think I've covered a little bit of fibroids in infertility, and it'll be a good hot topic for discussion. I am so looking forward to see what's going on. And I hope I finished on time too.
Yes, Selva Priya.
Yes, madam.
Yes, you can stop
sharing. I can stop sharing.
Yes.
Yeah, you can.
We can have the questions after 3 speakers.
Yes, madam. Okay, we'll do that. Okay, I'll wait.
Yes, chairperson.
Madam Tamil Selvi, madam, please unmute yourself.
Hello.
Yes, madam. Saraswati, madam. Good evening.
Hi, good evening. Nice to see you both, Anjalachi and Sampath. Congrats.
Thank you, madam. Thank you.
Okay.
Saras, good evening. Saras, good evening.
Anjalachi, good evening. I saw you.
Okay.
Thank you for calling me also. Tamil Selvi?
Ma'am, good evening, ma'am.
Good evening. How are you? Fine.
Fine, ma'am. Fine.
Very nice.
Saras, madam, can introduce Dr. Subhash, I think.
All right. So thank you very much, the organizers, for giving me this wonderful opportunity to be with you all. All of us know that fibroid in reproductive age is about 35 to 75%. And of course, in pregnancy, it's about 0.1 to 10.7. But in pregnancy, less than 50% of fibroids are only detectable clinically, right? And even though there are, as a previous speaker said, it's most of the time it may be asymptomatic. Likewise, even in pregnancy, it can be insignificant, but then sometimes it causes problems. So let us listen from Dr. Subhash, Dr. Subhash Malya regarding the pregnancy in fibroids. Over to Dr. Subhash. He is one second, please. MBBS, DGO, DNB, MNAMS, whatnot, everything. And diploma in gynec endoscopy. He is PVS Hospital and Baby Memorial Hospital, Calicut, Kerala. Chairperson elect, Foxy Endoscopic Committee of 21-23. Zonal Coordinator to Foxy President 2020. He is a Secretary, Calicut Society 2020 Kerala Chapter. and managing committee member IAGE 2019 and 20. Foxy Mentor Mentee Award. This is very important in 2019. Member of Foxy Endoscopy Committee. I think it's going on and the list is so much. I think with this I'll stop. Then I'll give, yeah. Dr. Subhash, over to you, Subhash.
Unmute பண்ணுங்கப்பா, அவனால unmute பண்ண முடியல.
Hello. Hello.
Madam, 1 minute. He is not able to unmute. He mentioned. Hey, Subhash, yes, he is there.
Hello, madam, Sampath, madam, thank you. Unmute pannite, madam. Right. At the outset, let me thank Anjalakshmi madam and Sampath Kumari madam for this wonderful opportunity and TNFOG for this wonderful opportunity. Again, I have sent my, actually I'm traveling right now. I will that's right. I've sent video to the organizers. I am here, ma'am. I'm live. I'm here from the start, ma'am. The show began, ma'am. I'm here. And the organizers, can you please play my video?
Vanakkam and Nandri, madam. And on behalf of my society and myself, I would like to thank Tamil Nadu Federation of Obstetrics and Gynecology for giving me a wonderful opportunity here. Thank you very much, Anjalakshmi madam, Kumari madam, and the whole team of TNFOG for giving this wonderful opportunity. Again, I would like to thank chairpersons for the evening, Dr. Tamil Selvi madam, Dr. Saraswati madam, and Dr. Anurada madam during this session. As I said, I bring warm greetings from Calicut. And the topic for today evening is, as you know, it's a fibroid marathon. And the topic for me today is about fibroid and pregnancy. Now, we'll start with the basics first, and then we'll go ahead with this. Of course, we all know about fibroids in pregnancy. But again, the prevalence of fibroids per se during pregnancy is always likely to be underestimated due to the ability of the ultrasound to detect fibroids, mainly due to the difficulty of differentiating fibroids from the physiological thing. So it's slightly difficult in pregnancy to make out about the fibroids. But again, what we have seen in the past few years was as the trend increases for the women, childbearing in the older women, chance of having a fibroid is about 12% to 25%. Almost about 1 in 8 patients to about 1 in 4 patients in the elderly ones who have fibroids.
Hello.
But despite the growing prevalence, the relationship between uterine fibroids and adverse pregnancy outcome is not clearly understood. Yeah. So my talk today is based upon trying to bridge that gap and try to have a common finding in this. Right. Now, prospective studies using ultrasound to follow the size of uterine fibroids throughout the pregnancy have seen that majority of these fibroids, contrary to what we think, do not demonstrate any significant change in volume during the pregnancy. But of course, the other one, that's about 20 to 22% of the fibroids that did increase in size and volume. Now, the growth was limited almost exclusively to the first trimester, that is, the first 10 weeks of gestation, and very minimal in the second and third trimester. So, contrary to what we were thinking, that it does increase, and even I would think, it would increase per se in the late trimesters and the second trimester. No, the maximum growth that was seen is seen in the first trimester. Okay. Now, effect of fibroids on the pregnancy outcome is on a this is most of these fibroids are asymptomatic. However, severe localized abdominal pain can occur if the fibroid undergoes the so-called red degeneration, which we are all very fond of. Fibroid in pregnancy, the first thing that comes on mind is about red degeneration. Now, torsion is something which can be seen commonly with a pedunculated subserosal fibroid or its impaction, right? And again, pain is the most common complication of fibroids in pregnancy and is most often seen in women with a large fibroids during second or third trimester of pregnancy. Now, this is something, since I took out the word torsion, is actually a very, no talk of mine would be complete without, laparoscopic video. So this is actually a video which I've got from my friend Dr. Nagendra Sardesh Pandey, which is a pregnant uterus with a torsion ovary. So you can see here he used a loop, you tie the loop, and since it's a pregnant one, you tie a loop on the underneath the uterus, the fibroid, and then so that, you decrease the vascularity around that, and then you separate it out. So there's not much of problem in these cases. Okay, you can see here. And of course, in a very early pregnancy, SLAP in pregnancy in early can be done in these cases. Right. Now, effect of fibroids on pregnancy outcome. Okay, let's go from trimester wise. The first trimester or the early pregnancy, what we commonly see is the miscarriage, right? Now, if you see the rates, the spontaneous miscarriage rates are greatly increased in pregnant women with fibroids compared to no fibroids. It's about 14% to 7.6%. Almost there's a twofold increase in miscarriage rates in pregnancies with fibroids. So when you see a patient with fibroid, always do think in mind that the chance of having a miscarriage is slightly higher. Now, the best part about this, the evidence in the literature does not suggest that the size of the fibroid is directly proportional. So contrary to what we may have been thinking, in terms of, when I say contrary to many of us, I include myself also, is that the size, the larger the size, the more is the chance of miscarriage. No, it's not so. Okay. Again, multiple fibroids does increase the miscarriage rate compared to the prevalence of a single fibroid. That's about 23%, about 8%. That's about threefold increase in that, right? Okay. Now, coming down to the next, is the location of the fibroid is also equally important in case of miscarriage. Now, early miscarriage is very common with fibroids when these are located in the uterine corpus than in the lower segment. And then with the intent, of course, with intramural or a submucosal fibroid, the chance of having a miscarriage is very high. The mechanism by which the fibroids cause spontaneous abortion is not very clear, but what has been speculated is increased irritability and contractility, the compressive effect of the fibroids, and compromise to the blood supply of the developing placenta in the fetus. Okay. Coming to the second part, that is the most common part, that's the red degeneration. It's more commonly in the second or third trimester of pregnancy, where there's a rapid increase in size that's causing the vascular deprivation and the degeneration. It may cause pain and tenderness, but the problem with that is it may initiate a preterm labor. Now, it's managed conservatively with bed rest and narcotics and prophylactics if indicated. And once the acute phase, if you're able to overcome the acute phase of pregnancy will definitely go towards the term, is what we have to remember. Right. The three main theories which have been postulated for the pain is when the rapid growth of the fibroid results in tissue outgrowing its blood supply, that leads to tissue anoxia, necrosis, and infarction. That's why in the mid part, you always have the area of infarction. Second is growing uterus results in a change in the architecture or the thinking of the supply of the fibroid, which can lead to ischemia and necrosis, even in the absence of fibroid growth. So as and when the uterine size increases, maybe the small amount of kinking of the blood supply does cause this. Again, release of prostaglandins from cellular damage within the fibroid. And this is a very important theory because you can see this when you give NSAIDs in these patients, antiprostaglandins in these patients, the pain definitely comes down. So that is why it's been supported by these observations. Okay. Now, coming to the second part of the miscarriage, the bleeding in early pregnancy. Now, location of the fibroid again determines the risk for bleeding, as we have seen. Bleeding in early pregnancy is significantly more common if the placenta implants close to the fibroid compared to pregnancies in which there is no contact with the placenta and fibroid. Obviously, when the placenta and the fibroid are nearby, there is an increased risk of increased bleeding in the early pregnancy. Then you see the statistics, it's about 60%, about 9%. That's about almost 6.5 times more chance of having a bleeding in these cases, right? Now, this is something, I can see the fibroid and you can see the fetus over here. So this is about 3.5 to 3.8 centimeter fibroid. But the best part is, it's evidently in the posterior wall, but this is not likely to cause any pregnancy-related complications, is what I would like to emphasize. Now, coming down to the late pregnancies, we finished the first trimester, we finished the red degeneration of coming down. Now, preterm labor is something which we have to be, always be worried about. But what has been found is pregnant women with fibroids are more likely to develop preterm labor. I think we all would agree on that aspect. It's about 16.1% versus 8.7%, almost 2 times chance of having a preterm labor. Now, people deliver with fibroid, the chance of having a delivery is about 16% also. So not only the preterm labor, the preterm delivery is also, rates are also higher. Not just the patient goes into preterm labor and then it arrests. No, even for the labor, the chance of this is almost about 2 times. Now, multiple fibroids and fibroids contacting the placenta appear to be an independent risk factor for preterm labor. So as I told initially, if you have multiple fibroids, if you have the fibroids which are contacted very close to the placenta, now these are the ones which will have more risk factors for preterm labor. The second aspect is the PPROA. Now, in contrast to what the studies or the speculation was, fibroids do not appear to be a risk factor for the preterm premature rupture of membrane. So basically, that is not much of a problem with the PPROM in these cases. Okay. Now, fetal growth restriction. Now, fetal growth does not appear to be affected in most of the cases. But when you go by the cumulative data and population-based study, women with fibroids have an increased risk of delivering growth-restricted infants. Now, these results were not adjusted for the maternal age or gestation age, so that's why there's one catch for these studies, and the fetal anomalies. So basically, large fibroids can compress and cause distortion of the uterine cavity, leading to fetal deformities, but it's a very, very rare thing. But whatever have been reported, most of these cases are with large submucosal fibroids. When you see these complications like dolichocephalic, torticollis, and limb direction defects, obviously due to the pressure effects of these fibroids. But these are more commonly seen in submucosal fibroids than the intramural or the subserosal fibroids. Now, again, this is another fibroid here. You can see the fibroid, which is in touch with the placenta. So what I have told now, it was about 5.5 to 6.9 centimeter retroplacental fibroid is shown. And this large fibroid is likely to interfere with the placentation and intraplacental blood flow, both due to its size and location. In turn, what is the problem with this is these patients may present with IUGR, placental abruption, or preeclampsia. That's why we have to remember that the location of the fibroid is also equally important and not just the size of the fibroid. To the placental abruption, we know the risks are conflicting, but the full cumulative data suggests that the risk of placental abruption is almost 3 times increased in pregnancy with fibroids than with no fibroids. Now, as I have been reiterating the last 3 to 4 minutes, submucosal fibroids, retroplacental fibroids, and fibroid volumes which are more than 200 centimeters cube are independent risks for abortion. For the abruption. Okay. And one retrospective study showed that placental abruption in 57% of women with retroplacental fibroids compared to just 2.5% of these women without that. So basically, when you have a retroplacental fibroid, as shown in the previous image I had shown, the chances are almost 57% of these patients, had some amount of retroplacental fibroids in these cases. The mechanism of placental abruption may be due to their diminished blood flow to the fibroid and the adjacent tissues, of course, which results in partial ischemia and residual necrosis in placental tissue, which is overlying the fibroid. So basically, when the placenta overlies the fibroid and there is residual necrosis and partial ischemia, that again would cause abruption in these cases. Placenta previa is another one. The relationship of these have been studied in only about 2 studies which I've got, both of which suggest that the presence of fibroids is associated with 2-fold increase of placenta previa. Okay, but what is more important is it has got nothing to do with the case of previous LSCS or previous myomectomy. It's an independent factor. So basically, fibroids per se will cause an increased risk of having a placenta previa. Okay, coming down to labor and delivery, and the malpresentation is more common. If you see in about 13% of patients with fibroids have malpresentation. Now, the reason for malpresentations are large fibroids, multiple fibroids, and fibroids in the lower segment. Now, of course, when you have a fibroid in the lower segment, definitely there is going to be some amount of malpresentation, and that again is an independent risk factor for malpresentation. Labor dystocia and cesarean delivery. Now, uterine fibroids per se are an independent risk factor for LSCS. More often than not, we tend to do they have a lesser threshold for doing an LSCS in patients with fibroids, saying that they're more likely to have any problems. Now, in a systematic review, what was seen is about 3.7-fold increased risk of cesarean delivery. It's about 48% to about 13%. This is partly due to increase in labor dystocia, which is increased 2-fold in pregnant women with fibroids, as I told in the previous slide. Now, malpresentation, large fibroids, multiple fibroids, submucosal fibroids, and fibroids in the lower segments are considered predisposing factor for LSCS. Of course, when you have malpresentations, there is no other go. When you have submucosal fibroid and fibroids in the lower segment, you have no option but to go ahead and do an LSCS for these cases. Again, is another very nice picture. You can see the placenta, the lower segment, and the fibroid over here. Now, what is more important is retroplacental fibrosis. Now, that's about 7.8 centimeter fibroid, which is in the lower segment. Now, given its size and location, this large fibroids will definitely interfere with the engagement of fetal head near term and normal progress of labor. But what is more important is the internal echogenic changes that you can appreciate over here are consistent with blood degeneration and maybe the cause for the patients in here. Okay. Now, there is another very important aspect, the latest study in 2019, if I'm not wrong, which is intramural non-cavity distorting myomas have an impact on placental histopathology, anatomic villus maturation, and vascular placental features with higher incidence of dysfunctional labor. And there's a very important study which says that, let's say, when you have fibroid non-cavity distorting, also placental histology is going to be, slightly different. Again, prevalence of obstetrical adverse outcome like the preeclampsia, preterm labor, and IUGR between the groups can be acknowledged and maybe explained with the translation of placental abnormalities into the clinical complications. Now, despite the increased risk of, now this is very, very important, which I would like to reiterate, even if you don't remember anything when we talk, this is very important. Despite the increased risk of cesarean section, the presence of uterine fibroids, even larger fibroids more than 5 centimeters, should not be considered as a contraindication of trial of labor. So please do give a chance of labor, a trial of labor for these patients, and LSCS should not be a consideration for. LSCS should not be done at the first go, right? Now, after delivery, the postpartum hemorrhage. Now, reports between the fibroids and postpartum hemorrhage are conflicting. Some of them say we do have increased risk, some of them say no. But when you have the pure cumulative data, it suggests that the PPH is significantly more likely in women with fibroid, for 4.5% compared to 4.4% in non-fibroids. So definitely, there's an increased threshold for PPH in these patients. Now, fibroids that distort uterine architecture and interfere with the myometrial contractions, leading to uterine atony and PPH, is the cause which has been said. Now, again, location of fibroid, intramural, submucosal, or subserosal have also a statistically significant impact on the risk of PPH. But contrary to what most of us would have thought, it is not the submucosal fibroid, rather it is the intramural fibroid which has got increased risk of PPH compared to a subserosal or a submucosal fibroid. But what is more important is please to remember, please to reiterate this, that you can see over here, 5.6% of the subserosal fibroid, they do have a risk of this. Now, the same mechanism may also explain why women with fibroids are at increased risk of hysterectomy also. Okay. Now, retained placenta. Okay, retained placenta was more common in women with fibroids, but only if the fibroid is located in the lower segment is what we've seen in the studies. However, full cumulative data suggests that the retained placenta is more common in all women with fibroids compared to control, regardless of the location of fibroid. Okay, but if the fibroid is more in the lower segment, then the chance of having retained placenta are very high. Right. Uterine rupture after myomectomy is a very controversial topic. Now, what was seen previously is, when you after an abdominal myomectomy, the chance of rupture is very less, of course, because of the better closure. Again, in a retrospective study of 120 women with delivering a following abdominal myomectomy, in which the uterine cavity was not entered, there were no cases of uterine rupture. However, to my favorite topic of laparoscopic myomectomy, there are very different conflicting reports. What was seen earlier in the initial phase was that the chance of rupture was slightly high. But what you have to remember is, when you think of rupture, it need not be intrapartum rupture. It can also be before the patient goes into a labor also. Okay, so that's all very important. But now we have a very good study from Dr. P.G. Paul sir and his team, where they have studied about laparoscopic myomectomy and the pregnancy and the delivery rate. They have said that the chance of rupture with the advent of Barb sutures, the advent of better uterine closures are very, very good. Let's not be biased that patient has had a previous laparoscopic myomectomy, so we need to have it. I'm not here to advocate that every case of laparoscopic myomectomy should be allowed for a trial of labor. No, I'm not here to say that. My own patients, with my own studies that I've seen is, few of my patients, almost about 25 to 30% of my patients have delivered. It's 1 in 3 of my patients have almost delivered normally without any problem. But again, as I saying, I will not reiterate that you have to take it, that every patient of laparoscopic myomectomy you have to allow for normal. No, there are many other things, as I said, the site of the stud, the number of fibroids, of closure, whether you entered the cavity or not. No, all these are very, very important. Okay. Now, coming down to the next aspect is better safe than sorry, as I keep saying, we always be very careful about these things. Right. Now, the pain management, most common complaint that patients with fibroids have, other than regeneration in pregnancy, is the pain management. Fibroid pain during pregnancy usually managed conservatively with rest, hydration, and analgesics. Inhibitors can be used, as I said, can use. But of course, be careful that it may cause the premature closure of ductus. Again, pulmonary artery hypertension, necrotizing enterocolitis, and intracranial hemorrhage are known side effects of giving a prostaglandin inhibitors. Now, because if the pain is very severe, you may think of even giving narcotic analgesia or epidural, but again, it's very rare. In surgical management of myomectomy, as I keep saying, the only indication for that would be a case of torsion. Right. Now, we all know this great man. Now, summarizing my talk, we all know about this great man, Victor Bonney, as we all know, 1870 to 1953. Now, what he teaches is, when you have a cesarean myomectomy, his views were very, very simple. He said, no, right? But now, cesarean myomectomy, the moot question now is for cesarean myomectomy to do or not to do. So let me see how I can try to help you out. Now, let's not be like this. let's not be very, very rigid in our thoughts and thinking that no, we should not be doing it. No, let's come out of that, And now, what is the fear with this? Why? Because, the principle earlier was that, that now that patient can have an hysterectomy, there can be torrential bleeding. But now, this thing has changed. We can concurrently perform, myomectomy at the time of LSCS in in most of the cases rather. Now, but again, very, very important, as I keep saying, taking the basic principles of medicine in consideration. Okay. Now, only those fibroids removed which may require surgery later, and more importantly, which are easy to remove. Not merely just because you have a fibroid, no, don't go for it. Okay. Now, 4 studies, in clinical cases, I think that will help us out in making it very easier for that. Now, this is the first case where you have a 36 weeks, pregnancy primigravida, referred as a case of large fibroid with malpresentation, married for 6 years, spontaneous conception. On examination, it was a term uterus with fetus in oblique position and large anterior fibroid. Now, in this case, elective CS was done because of these indications, and consent for myomectomy and hysterectomy was also taken, as we would do always. Uterus is sterilized after surgery, and say, this is how it looked like. You can see the uterus here, initial, and then large anterior fibroid. Myomectomy was easier in these cases. Perform myomectomy after liberal infiltration of diluted vasopressin. Cavity was obliterated, and postoperatively the patient went home uneventful. Right? And that's how it looked like. This is the fibroid just removed. Now, in the second case, as we said, it's an easy case, so there's no much of doubt about it. Anterior fibroid, fundal fibroid, we just remove it. Now, this is another case of 38 weeks of gestation, which is a good case. Now, this patient was, having a high floating head, and a mass was actually felt in the lower segment of the left side. And the unfavorable cervix, so because of obstetric indications, we did an LSCS, but the ultrasound that it showed was, you can see a large broad ligament fibroid here on the left side. Right? Now, in this case, he underwent elective CS. The patient was told that we may do a myomectomy at the time of CS. We take all the consent, we did all the blood transfusion, blood and everything ready in this case. But when after uterine closure, it was seen there's a big fibroid running on the left side of the broad ligament. It's a large blood vessel running over the fibroid. Sometimes I keep saying, there's no place for heroics here. Better be safe than being sorry. So we deferred that. Myomectomy was not performed because of the location and vascularity. Postoperative period was uneventful. Of course, you would feel bad that you're not done a myomectomy, but that's the right decision there. So the patient went home happily. We are also very happy with that. Now, as I keep saying, better be safe than sorry in these cases. Right. Case 3 was 37 weeks of gestation. Again, admitted for elective CS from each presentation. Now, again, slight indication that there's a fibroid in this. The USG showed 10 to 9 centimeter fibroid on the left side of the uterus and its main body. Now, when you went inside, it was actually elective CS followed by myomectomy with subserosal fibroid. There was no controversy here. It was a subserosal fibroid, very easy. Why should we allow the patient, to go back and come back later for another case? And we opened up subserosal fibroid, ligated it pretty well, and then the postoperative period was uneventful. Right. Now, this is another case, which is a slightly controversial one, which is referred as fundal head was much more than the expected gestation. Examination showed the uterus up to the xiphisternum and the fetus in the longitudinal line. On ultrasound, there were 3 large fibroids, 1 anteriorly in the lower part and 2 in the upper fundal region. The patient went into spontaneous labor because there was no non-obstructive indication for an LSCS. Patient was allowed for a normal delivery, but then there is fetal bradycardia in the first stage. So then we had to unfortunately take the patient for LSCS. Now, emergency CS was done. Uterine incision was closed in 2 layers with 3 large fibroids in these cases, as shown here, which could be easily be removed in these cases, and you close the patient. That's how I think I have told in a nutshell about 3-4 different scenarios and how would be approached to this, to say what will be the management and LSCS in these cases. Now, role of vasopressin, there is no doubt. It's an excellent point. You use about 20 units of vasopressin in 200 ml of normal saline and inject it pretty well. Be very liberal with the vasopressin. This is even in normal myomectomy you have been very liberal. In this case, you have to be extra liberal. In this case, use very good vasopressin. Of course, be very careful that you do not inject into any vessel. That's a hypervascular uterus, so be very careful. Always withdraw it. See that you are not in any vessel, and then you inject it very slowly in dilute vasopressin. There is no doubt about this. The role of vasopressin is very, very important in these cases. Now, summarizing my talk, management of fibroids during the antenatal period is never surgical except torsion of penetrative fibroid. Fibroids in pregnancy are very common, and the incidence will definitely increase in future due to the late marriages. myomectomy at CS is not absolutely contraindicated as was believed earlier, and as I've been trying to impress upon you in the last couple of minutes. And the decision definitely depends on the location, size, and number of the fibroid. The risk and benefit to be evaluated in every case, and the decision has to be individualized. I keep saying the only surgeon who does not encounter complication is the one who is not operating. As long as we are operating, complications can occur even in the best of hands. It is vital that they are promptly recognized and immediately addressed. And the importance of proper training and the value of experience, as our teachers would always say, is very, very clear. You need to have, the experience and the importance of proper training, as our teachers would have given us for doing these cases. Thank you very much. Thank you very much, Sampath Kumari Madam and team, for giving me a wonderful opportunity. I'm very thankful to Sampath Kumari Madam for
Subhash? Yes, Saras Madam?
Yes, ma'am. Yes, ma'am. Yes, madam. I have overshot my time by about 6 minutes, and sorry for that, ma'am. But then I thought I can give you a good take-home, ma'am.
Fantastic, Dr. Subhash. Even you are traveling, you made it. The presentation has reached TNFOG. Thank you. Saras Madam? Yes, Tamil Chelvi?
Yes, ma'am. Sir, thank you. It was indeed a wonderful presentation. Right from conception till cesarean myomectomy, you gave a very clear idea. And thank you, sir. Thank you.
Thank you very much, ma'am.
Thank you, Subhash.
Anuradha,
But if any questions in the chat box, you answer, if possible.
Yes, ma'am. Yes, ma'am.
Yes, okay. We will go to the third speaker, Rajshri. Dr. Rajshri?
Yes, ma'am. Yes, ma'am.
Anuradha Madam.
Anuradha Madam. Anuradha ma'am.
Yes.
Ma'am?
Yes, I'm here. Am I audible?
Yes, ma'am.
Okay. Good evening to one and all. At the outset, I would like to thank the organizers for giving me this opportunity. Thank you very much, Dr. Ajilakshi. Thank you, Dr. Sampath Kumari. All of us know fibroid or leiomyoma is the commonest benign tumor that we come across in our practice. It is hormone dependent, and it's more in reproductive age group. And what it does in reproductive age group, infertility, that has been dealt with Dr. Selva Priya, and even if she gets pregnant, what complications she may face, that was dealt with Dr. Subhash. Most of the cases we come across that happens around 40 years, late reproductive or just premenopausal. They come with menorrhagia. But sometimes we do come across cases in menopausal or post-menopausal age group also. Especially now, this master health checkup is very, very common. It's not uncommon. The patient will bring you ultrasonogram report, post-menopausal age group, and show some finding, fibroid 1 centimeter or 5 centimeter or 3 centimeter, like that. And she can present with symptoms also, lower abdominal pain or lower abdominal swelling. So we have a very good speaker. Madam doesn't need any introduction, Dr. Vijayalakshmi Seshadri. She is a senior consultant OBG, Sundra Medical Foundation, President-elect Oxy.
Anuradha Madam, President Oxy. Sorry for that correction. President Oxy.
Yeah, President, I'm just wondering. President Oxy.
That is an old CV that they are projected. My old photo, old CV. So perhaps doesn't matter. No issue.
And she is the chairperson, research committee, member quiz committee, Foxy and IMS, past South Zone coordinator, Safe Motherhood Committee, Foxy, past Chennai chapter secretary, IMS, organizing chairperson, ISOPAP Conference, Chennai 2017, won best paper award in AICOG 2014 Patna, contributed to Foxy Book of Quiz, and also wrote chapters on hirsutism in Foxy Manual and in endocrinology. Now I request our Dr. Vijayalakshmi to throw light on this topic.
Can I share the screen? Thank you very much, Dr. Anuradha. And at the outset, let me thank Dr. Sampath Kumari and Anjalakshi Madam for this wonderful opportunity. We know as gynecologists. Hello, I'm okay. Yeah.
Yes, ma'am. You started.
So we all know. Hello.
Yes,
we all
ma'am.
know that fibroid. Somebody is speaking. I think everybody else needs to be. We all know that fibroids are very close to our heart because day to day we keep seeing them, as all the previous speakers have spoken, that it can occur at any age, and we have learned from the young gynecologists, Niranjana and Divya, how it originates and how it presents and what is the diagnosis. So in fact, my job is made much easier because the entire presentation today of the CME is on fibroids. And so we can really think about a particular focused discussion on what exactly happens in menopause and how is it different from the fibroids happening in other age groups or other conditions. So we all know that the pathophysiology deals with lots of causative theories on fibroids, but we see them so often that diagnosis is never a controversy except in certain cases. So in younger age groups, in infertility, in pregnancy, it has been dealt so much in detail by all the eloquent speakers ahead, that now we are left with the end of the other part of the discussion, where in the middle age, how do we really look at these fibroids and how do we tackle them? Now, the perimenopause and menopause is a very good state where I think we don't have to worry too much about the complications that occur in pregnancy. We do not worry about what's happening for the infertility, and we do not really worry about lots of issues related to uterus. And therefore, earlier ages, we know these menopausal women used to have a comfortable tackling of fibroids by simply going in for hysterectomy, and that would solve the entire issue of menopausal fibroids. But now we are in a different era, and therefore we have moved away from the resections and removals. We have gone over to the organ sparing, and therefore there is a lot of scope for understanding what exactly these menopausal fibroids present with. Are they different in incidence? Do the behavior of these fibroids change? And how do we have a difference in the management of fibroids in this menopausal age group? And that becomes very important as we move ahead. Now, as has been reiterated even by the previous speakers, almost 60 to 65% of the women, when they reach the age of 50, might end up with fibroids. They have become so common that any ultrasound report with the patient presenting with fibroid, they themselves come and suggest, I have fibroids. Now, as has also been spoken by the earlier speakers, more in the African American women, and even at the age of 21 to 30 years, they develop multiple fibroids. And the peak growth of fibroids happen in the perimenopausal age group. And we must understand, probably because it has been explained that although postmenopausally there is a natural regression, but in the perimenopausal period, because of the hormonal changes, there is some estrogenic flush. And this fibroid being an hormone-dependent tumor, there is perhaps a peak growth during these years. And this has been well illustrated by a huge study of California study of 1,790 women, and they said almost 30% new fibroids originate at 45 to 49 years. And in fact, many of them are seen beyond 50 years also. Now, so what happens? Why are we seeing so many fibroids even at the age of the perimenopause or menopause? So perhaps there are some pre-existent fibroids which we have not dealt with at the younger ages, or perhaps we have missed, or perhaps the patient never presented with any complaints, because quite a number of these fibroids are asymptomatic as well. So maybe we left them off at the younger ages and they continue to be presenting to us at the menopausal age. Or there are some residual fibroids because, as we know, we have gone in for a conservative management and therefore maybe we remove the bigger fibroids, or maybe we just leave off the smaller fibroids which are there as seedling fibroids just seen through the imagery, and therefore these fibroids might have grown by the time we come to the perimenopausal or the menopausal age group. Or maybe they are recurring. Maybe even after we remove, they grow again and therefore present to us at this age group. There could be, of course, new fibroids originating as well, but the numbers are less, and quite often it is the residual or the pre-existent or the recurrent fibroids happening at the younger age groups that present at the menopausal age. Now, what risk factors have also been elucidated in detail? Hypertension, obesity, nulliparity, long-term stress, vitamin D deficiency has been very closely associated. We know now vitamin D is found responsible for lots of issues, whether in obstetrics or in gynecology. Maybe we are detecting more of vitamin D deficiency or trying to associate more of vitamin D deficiencies, but they have been found as a positive risk factor for fibroids. And then there are also, from the genetics, we have moved on to the epigenetics and to the causative agents like estrogens, like endocrine disrupting chemicals, and those exposures can also predispose them to the manifestation of a fibroid. Now, obesity is a very characteristic risk factor, and especially in the menopausal age group, where many women become obese, especially the truncal obesity, and they say the 10 kg addition of the fat, there is an increase of risk of development of fibroids by 20%. That was a very characteristic study done by Ross et al. So obesity is a major risk factor, and we all know that obesity predisposes also maybe because of the peripheral conversion of the androstenedione to estrogens in these fatty tissues, and therefore that is a known risk factor. We have also seen how they have all beautifully explained how fibroids originate, and because it's a single genetically altered mesenchymal stem cells which gives rise to fibroid. Not every myometrial cell gets converted to fibroids. There are certain cell groups which have the predilection of converting to fibroids. These cells might undergo somatic mutations. There are cells where the sensitivity to the gonadal hormones is a little more, and that is why not all women develop these fibroids, and not all cells convert into leiomyomatous cells. There could be a loss of tumor suppressor factors, and then there could be expression of the vascular endothelial growth factor, or the tumor growth factor, or the platelet growth factor, or the epidermal growth factors. Cytokines, chemokines, they have all been put into some kind of role when we are talking about the origin of these fibroids. We have seen in detail the pathophysiology and the etiology, and therefore I'm not going to go into the details of this. But what happens, let us come to focus area of the perimenopause and the menopause, where the estrogens and progesterones go down. We know the gonadal hormones go down, and the mitogenic stimuli are taken away, and therefore, though they normally act through the autocrine and the paracrine messengers, and they contribute to the formation of fibroids, there is good amount of evidence from the epidemiological, clinical, and the experimental viewpoints, and therefore this is not debatable. But at the same time, when these withdraw and we do not have there is a forming, the fibroids go into a natural regression, then why is it that not all menopausal women go in for a complete dissolution of fibroids? Now, normally they can express by view of delayed menopause, either the menopause never arrives, some kind of uterine bleeding keeps happening, and patients also think maybe they are going in for a delayed menopause. And we all know the perimenopausal age where there is irregular bleeding pattern, and therefore the patient also thinks, the family also thinks, and by the time they approach us, it is our duty to rule out the existence of these fibroids, like any form of abnormal uterine bleeding, which we will be evaluating to make things clear. The pain could be there, and depending again, some are totally symptomless. Even huge fibroids are quite asymptomatic, but sometimes even some kind small multiple fibroids can cause pain. The pressure symptoms, as we all know, more by the subserous fibroids, but can happen in huge fibroids, and they do press upon the bladder and the rectum and cause subsequently those symptoms related to those tracts, and also by the pressure on the ureter may cause a hydronephrosis. So those pressure symptoms can also be the initial presenting symptoms. Sexual pain is understandable with multiple fibroids and occupying almost most of the uterus. Now, diagnosis again has been dealt with in great details. I will just make a mention. A clinical diagnosis always comes first. Whatever the radiological or the laboratory investigations can happen now, patients can come to us with the ready-made reports of these. I always tell them we don't treat scans and x-rays, we need to treat you. So first, let us know what is your symptom, because some of them don't need that much attention, while some of them really need a complete management. So clinical picture based on that about the intermittent bleeding or irregular bleeding or heavy menstrual flow, kind of any abnormal uterine bleeding, fibroids have to be ruled out. And of course, imaging, the ultrasonogram, the CT MRI, the sonohysterogram, and of course, in some cases, diagnosis is made only by laparoscopy or hysteroscopy. So again, this has been dealt with in detail by Niranjana. Now, the uterine leiomyosarcoma is an entity which has also been dealt with, how we can diagnose with the LDH ratios, LDH3 and all. But we all know that although leiomyosarcoma is a rare entity, and the tissue diagnosis usually is an accidental diagnosis after the removal of the specimen, yet that should be hanging on in our mind, but at the same time not overestimating the incidence of leiomyosarcoma is very important. And most patients of these leiomyosarcoma fall in the perimenopausal age group. Of course, there is a very poor prognosis attached to it, and rapid growth is one thing which is to be suspected highly for this. We all know fibroid is a very benign tumor and is a very, very slowly growing tumor. When we keep them for observation and study, and then after a year also, we look at those scans, hardly half a centimeter, 1 centimeter of growth happens in these fibroids. So when there is a rapid growth, the leiomyosarcoma can come into play, and we need to worry about them. And of course, not all fibroids, like in other places, get converted into a malignant potential, and they say it is entirely a different entity which are destined to go in for either a uterine leiomyosarcoma or and that is much different from the leiomyomas or the stumps, the malignant potential tumors. And then, so now, this particular age group, do we manage the same way as in other age groups, or do we have some other options open to us? Of course, we all know as the menopause sets in, because of the withdrawal of the gonadal hormones, we do have a natural recession of these leiomyomas, and therefore a conservative management can be definitely done, as we have been doing even in the younger age groups. Here, the scope is even more, and of course, we need to have an observation and follow up at a particular periodicity. And then the general management is important. We know that they do present with abnormal uterine bleeding, and therefore the cover-up for the anemia correction and the antifibrinolytic drugs, which are quite efficacious, because in fact they say tranexamic acid does not just act as hemostat, but it also has a potential to degrade and necrose the fibrotic tissues and therefore may help. And of course, vitamin D supplementation has also been taken into the therapeutic armamentarium. Surgical, again, we know is always been a complete handy care for these menopausal myomas. But again, hysterectomy is a definitive surgery, we all know, but we have moved away from it also. We need not do in every case. We can keep them for a follow-up. Of course, myomectomy, laparoscopic, hysteroscopic, abdominal, again, hysteroscopy, laparoscopic, vaginal, abdominal, and robotic. Any of the procedures, depending on the surgeon's choice, the skill of the surgeon, and of course, the patient's choice or the patient status can be done. The focused ultrasound is again a very big specialty. It is not reachable to everyone. It cannot be done in every setting, and therefore has its own limitations. The uterine artery embolization, an invasive radiological procedure, was brought in 1994, and lots of studies have gone in, but the best study has been by the Hopeful study, which also had a 5-year follow-up, and they compared the uterine artery embolization in 972 cases against an hysterectomy of 780 cases, and they found the results were equally comparable. There is also a thermal ablation radiofrequencies management which can be done. So let us move on to the most important therapy. All those previous therapies that I just spoke, all of us are very familiar. But what is important in this age group is the endocrine therapy, where we can consider the GnRH agonists, we can consider the antiprogestins, which are the selective progesterone receptor modulators, and of course the selective estrogen receptor modulators, and the LNG intrauterine system, and the aromatase inhibitors. The GnRH agonists commonly are leuprolide acetate and triptorelin, which are effective, and we know they have been found quite effective if used continuously for 3 months. But only the problem is the moment the GnRH agonists are stopped, the fibroid size recurs, and therefore it is mainly used for the preoperative intervention to reduce huge fibroids so that surgery becomes feasible. Of course, during that time, we do have a control on the bleeding as well as on the uterine volume. Yeah, how long can we use? We can use up to 3 to 6 months, but generally beyond 3 months, the menopausal symptoms take a heavy toll and patients usually get admitted, and therefore we need to use them with discretion. The side effects we all know in the long run, of course, apart from menopausal symptoms, they do affect the bone health. These selective progesterone receptor modulators, which are the newer drugs in the management protocols, are the mifepristone, ulipristal acetate, and azoprisnil. And the major dimensions which we are looking into is that by the bleeding, the amount of the fibroid size and the uterine volume, and of course, that we will have to take care of the tolerance of the patient, the compliance of the patient, the side effects of these drugs, and of course, their relationship to the endometrial effects, because we know there is always a crosstalk. Whenever we are dealing with the myometrium, there is a crosstalk with the endometrium as well. And therefore, we need to think about them. There has been in the RCOG guidelines in 2016, the Kinza Yunus et al. Presents a huge study based on the evidence-based management of uterine fibroids by the SPRMs, and they all say it's quite satisfactory. And these in the selective estrogen receptor modulators, we have tamoxifen. We know quite commonly used after the breast malignancy. They do have a selective proliferative effect on the endometrium, but apart from that, they are quite antagonistic and therefore they may have a positive role in the shrinkage of the fibroids. The raloxifene has been found to be better than tamoxifen in several studies, and even in about 100 women have been studied over 2 groups with 60 milligram per day, and they have even gone up to about 180 milligrams per day. The aromatase inhibitors letrozole comes handy again because the aromatase enzyme is very well expressed by the leiomyomatous cells, and therefore they convert the androstenedione to estrogens. And so when we are giving aromatase inhibitors, this natural estrogen production from the androstenedione is cut off, and therefore they can potentiate the shrinkage of the fibroid. The levonorgestrel intrauterine system is again a little bit of controversial, because we know on one hand we speak of progesterone as potentiator of the fibroid, and on the other hand we say we may give the levonorgestrel intrauterine system. But what they say is perhaps because of the endometrial decidualization, which is caused by the local progesterone, there is a control on the abnormal uterine bleeding, and therefore there is a big systematic relief. Of course, the rate of expulsion of these intrauterine systems have increased during the presence of fibroids. Whether they shrink the fibroids, whether they reduce the uterine volume, there are lots of differences in the studies, and they may cause even the apoptosis of these myomatous cells, and therefore they may help in the fibroid management. The estrogens and progesterones. Now, what happens in this menopausal age group? Nowadays, we are also talking so much about the hormonal therapy, the menopausal hormone therapy. And are we into a controversy if we were to talk about the menopausal hormone therapy in these perimenopausal and menopausal women who have symptomatic who are symptomatic because of the hormone depletion? And we all know already we give hormone therapy with a lot of clarity, with a lot of understanding, and with a lot of care. And in fibroids, estrogens and progesterones can rescue the fibroid growth from the effect of menopausal ovarian quiescence, meaning they do have a negative effect. And so we need to be very careful. Tibolone, of course, is one drug which has the androgenic, estrogenic, and progesterogenic effects. It's a synthetic steroid, and it has been found not to contribute to the increase in the fibroid size. And maybe that could be a choice if we are aiming at giving the menopausal hormone therapy wherever the fibroids are coexistent. The transdermal estrogen and the medroxyprogesterone acetate come second in the list, but again, they are not a very preferable drugs because of they increase the fibroid size. Again, so many huge studies have been done on this, and Elisa Moreau et al. Has studied in detail and has presented in the 2019 very recently on the 1122 women. And all these studies, you can see there is no dearth of the studies on the menopausal hormone therapy with the coexistent fibroids in these women, and all of them have studied with different types of estrogens and progesterones, and they say all of them find the menopausal hormone therapy are more likely to increase the size of fibroids, and therefore should be reserved and should be guarded with the usage. Of course, the common consensus is also that the initial 2 years, they increase the size of the fibroid, but later on the fibroid volume maintains and therefore is not so detrimental. But we all know there is a caution in the usage of the hormone therapy to the best possible dosage for the optimal period and for the optimal reasons. And therefore, we need to consider them when we are talking about the menopausal fibroids. And I think that brings an end to my deliberation on the fibroids at menopause and perimenopause. Thank you very much. And because there was so much of coverage before me, I thought I'll just keep my talk focused to this. Thank you very much. Thank you, the organizers and chairpersons. Thank you.
Hello.
Thank you very much, Dr. Vijay.
Madam.
Excellent presentation. Yeah, you rightly put it forward that surgery is not a choice. Perhaps 2-3 decades ago, that was the only choice we had. But nowadays, the era is for organ preservation. And there are a lot of drugs to choose also. So we would like to have give a medical treatment first, then only we resort to surgical management. Thank you so much, Dr. Vijayalakshmi.
Thank
I
you.
would like to thank all the chairpersons, Dr. Tamil Selvi Sedupati, Dr. K. Saraswati, and Dr. Anuradha CR, and the speakers. I would like to go ahead with the next session. It was an excellent session. I would like to thank all the speakers.
Thank you.
Actually, one question you can ask the
Yeah, there's one question for Dr. Selvapriya. How to avoid a myomectomy scar rupture and what suture material should be used?
Anyone?
Hello?
Hello, Priya. Subhash, would you like to take that question?
Is there?
Yeah, ma'am. To avoid the scar. I mean, the question was how to avoid a myomectomy scar. Is it, ma'am?
Yes.
Rupture. How to avoid a myomectomy scar rupture and what suture material to be used?
Yeah, ma'am. Definitely, ma'am. It's not the suture material that matters, ma'am. It is how well you close it. Many a times, what we always think is that we have to close it very tightly, and in that process, we actually cause more of necrosis. So basically, it's good deposition without any dead space being left behind. I think that is what matters. Now, of course, laparoscopic
Yes, he has got that. So
was initially thought of very lot of disruption, and in fact, the advent of BAF to
think
am I audible, ma'am?
Audio is breaking up.
Okay.
Well, sure.
Anyway, Dr. Parikshit can also answer. Subhash is not heard.
So I think I kind of would like to just take Subhash's point forward that it's not only the question of the suture material. Of course, we know that you should use something which is delayed absorbable. So polyglactin is fine. There are varieties of polyglactin which are now available, especially for laparoscopic surgery. So barbed sutures, as they are called, they are all right. The important thing, according to me, is the technique. I mean, the closure in 2 layers. That's what I would like to stress upon, and a good apposition of the tissues without dead space being left. I think that's what will give us a good strength to the scar. I think most of the times that's what should carry us through.
Thank you, Dr. Parikshit.
Thank you, sir.
You can pose the question.
Thank
Welcome,
you,
Dr.
Vijay.
Parikshit.
Hello. Thank you.
Welcome. We will go with the questions. One minute. Delegates, please answer this question.
What is the effect of fibroid on pregnancy? Except which of these is not an effect on pregnancy? Miscarriage, malpresentation, preterm labor, macrosomia.
This is only for delegates, not for the faculties.
Faculty also learn. Faculty also learn in CMEs.
Chitrakala, after this, you can post the answer of our first session winner.
Okay, ma'am.
Now, ma'am, is she posting now?
Yes, first session we can tell.
Chitrakala?
Hey, let it finish.
Oh, okay.
Thank you. Dr. Atul sir is still there. Anyway, we are happy to have him. Yes, for the first session, the winner is Dr. Nandini Raman from Chennai. The question was the hysterosalpingography is better for fibroid diagnosis. Intramural, subserous, submucous, and cervical. The answer is submucous. Yes, Dr. Rashri, we can go with the third session.
Yes, ma'am. We will move on to the next session, which is the panel discussion. Can I have the slides, please? Welcome, sir, Dr. Parikshit. He is the moderator of the session. He is a consultant, Ashwini Maternity and Surgical Hospital and Center for Endoscopy and Assisted Reproduction, Mumbai. Consultant, Jupiter Hospital, Thane. Honorary Professor, Pacific Medical College, Udaipur, consultant for assisted reproduction at 16 centers. Is treasurer Foxy, chairperson Safe Motherhood Committee, Foxy 2014 to 17, postgraduate teacher and examiner, College of Physicians and Surgeons of Mumbai, and examiner for MRCOG Part 3, managing committee member, Mumbai OBGYN Society. He has several awards and about 100 peer-reviewed publications in index journals, CME publications and textbooks. He has authored 4 books in OBGYN, on the editorial board for 4 index journals. Welcome, sir. Now, can I have the panelists one by one? Can I have their CVs, please? Dr. Vanita, welcome, Dr. Anita. She's our own EC member, OXY. She's the director, Sunrise Laparoscopic Center, Chennai, teaching faculty, EISE Chennai. She's the winner of Foxy Dr. Suli Rudrasinha Award, ACOG 2011. Welcome, Vanita. Can I have the next slide, please? Dr. Victoria Johnston, she's a past secretary of Trichy OBGYN Society, member of Scientific Committee of Trichy OBGYN Society. She's a consultant, Janet Nursing Home, Trichy, ART consultant, Janet Fertility Center, Trichy. She has several awards and achievements. Recipient of Foxy Dr. Durusha Distinguished Committee Service Award 2016. Next slide, please. Welcome, Dr. Damodhar Rao. He's a consultant in OBGYN, infertility, laparoscopy at Rao Hospital. He is a diploma and fellowship in laparoscopy and also a fellowship in reproductive medicine. He is a Tamil Nadu IAGE Joint Secretary 2019-2022. Co-convener of Special Interest Group Endoscopy Indian Fertility Society 2020-2021 and Treasurer Coimbatore Chapter ISA 2019-2011. He has several awards and achievements. He has organized many hands-on hysteroscopy and laparoscopy workshops. The Foxy Future Award of UVA Foxy South Zone 2019. He has contributed to various articles in journals and chapters in textbooks of infertility and endogynecology. Next slide, please. Welcome, Dr. Saravana Kumar. He is the Secretary, OBGYN Society of Salem, Professor and Head of the Department, Annapurna Medical College, Consultant, Malar Maternity Hospital, Salem. He's initiated and trained young doctors in operative laparoscopy in Annapurna Medical College, and his field of interest is high-risk obstetrics and gynae endoscopy. Next slide, please. Welcome, Dr. Vani Madhavan. She is presently consultant at Vadivu Subramanian Nursing Home, Erode, Finance Secretary of Erode Obstetric and Gynecological Society, lifetime member of PCO Society. Next slide, please. Welcome, Professor Jessie Lionel, Professor of Obstetrics and Gynecology at Christian Medical College, Vellore, with over 30 years of experience in tertiary care. She has over 20 peer-reviewed publications and has written training modules for NACO. She established and directed the prevention of parent-to-childhood transmission of HIV program at CMC Vellore. She has over 30 years of teaching experience at CMC Vellore. She is a clinical associate lecturer, Flinders University, Australia, and president of Vellore Obstetric and Gynecological Society 2014. Welcome, madam. I now request Parikshit sir to take over the session.
Thank you very much. And I'll just start sharing my screen. And as I'm doing so, I must express my gratitude to the office bearers of the TNFOG, Dr. Anjalakshmi, Dr. Sampath Kumari, and Dr. Vijay Lakshmi for the kind invitation to be a part of today's program. And I must say that the previous session has made my life a lot simpler. And I'm sure the panelists will also echo this sentiment, because quite a bit of important material has been covered. And what we are going to do is the case discussions. And, applying these technologies, applying these solutions to appropriate scenarios. So we are going to take a problem-based learning approach. Hopefully there'll be some important practical take-home points for the audience, and we'll try to discuss 3 to 4 case scenarios. I acknowledge that we are running a bit late, so I'll try and keep the questions and answers as brief as possible. So let's go to case 1 straight away. We have a 32-year-old single woman. She comes to the clinic with a pre-employment check ultrasound, which shows a 6 centimeter sized intramural fibroid in the posterior wall. Her periods are all right, regular, just mildly painful. She occasionally uses a simple analgesic now and then. Average flow, no pelvic pain, dyspareunia, bowel or bladder complaints. And she's at your clinic, and she wants some sort of direction and counseling. So let me start with Dr. Vanita. She's concerned, this woman, she's concerned about the fibroid and wants your advice as to what she should do. How would you counsel her? What do you tell her?
So a mere presence of an ultrasound report does not mandate treatment. Since she's asymptomatic, I would definitely counsel her with regard to what she needs to do. I would just call her back for an annual ultrasound, talk to her about the symptoms which need to be really worrisome. I would tell her about if she has menorrhagia or she has pressure symptoms. I would ask her to come back to me. Otherwise, I would put her under a constant supervision. Every year, I would call her for an ultrasound, or sometimes even 6 monthly, so that at least they come up once a year.
Right, sure.
At this point of time, I wouldn't consider neither medical treatment nor surgical treatment on her.
I think that's a very wise counsel that you have provided her. But she's not very convinced about allopathy in general and doesn't really trust doctors. And that's a situation that we find ourselves in very commonly, Dr. Victoria. I'm sure you agree. So she is interested in some sort of natural cure for the fibroid. Can you give us some advice about this?
Good evening, sir. Thank you
Hi,
for this opportunity. Sir, as it is, she's around 32 years old. I think we should advise her some lifestyle modification and maintain her BMI, because obesity will predispose to an increase in size of the fibroids, and maintain a good lifestyle of exercise and diet. And probably we can give her some vitamin D supplements if she agrees to that. And they say that green tea is also good, sir, as a natural cure. But as a gynecologist, we would actually look into other factors like her age and whether she's keen on getting married and having a family. So according to that, I may counsel her, sir, further, depending on what her requirements are.
I think Dr. Victoria has given very good advice, which all of us can take to heart. Maintain your weight at a normal range, and a lot of health problems, including fibroids, they will at least not worsen. If they don't come up, it's okay, but at least they won't worsen. I agree with that completely. So I think this has been stressed on quite a bit in the whole program, that a lot of women have fibroids, but ultimately, a very small proportion of them are going to be symptomatic, and only that small proportion of women are actually going to need some treatment. So the counseling highlights, which Dr. Vanita said, is that most of these tumors, they are largely benign. I mean, a vast majority, and they usually grow only very slowly, and they can be managed medically for some time, but ultimately they are cured only surgically, and they rarely present as emergencies. So the advice that Dr. Vanita gave, that we can take a very conservative view at this point. And what Dr. Victoria said, that let us look at an overall picture, what is her current status in life, etc., and then we can formulate some kind of strategies. So when we are practicing conservatism, Damodar, I want to ask you this: which fibroids can generally be left alone, without any treatment?
Yeah, fibroids which are subserous mostly will not, give us any problems usually. Unless they're of a very large size. I think you could use a cutoff of about maybe 8 centimeters or something like that, which I think something about 8 centimeters might cause pressure symptoms and things like that. that is subserous one is the one which we can really not give too much of attention to. Intramural fibroids, again, it can vary based on which grade, Figo grade staging it is. If it is something like more than 4, probably again can be left alone. And if they are less than about 4 centimeters in size, again, that's a very gray area. Figo 3 is also a very gray area. And again, it depends on what the patient has come to us for, if it is for fertility or whether it is just menorrhagia. So that also is to be taken into account, or whether she's just, perimenopausal or something like that.
Sure.
So submucosal fibroids, I think definitely will need attention. Something that is Figo maybe 3 and 4, again, depends on her symptoms.
Yes.
So symptoms are the major ones that will actually guide us as to whether we should touch it or treat it or not. If she's asymptomatic, I don't think we have to do anything about it if she's not for infertility.
Yeah, I think that's a interesting way of looking at fibroids which are asymptomatic, Damodar. I like that concept that, you look at symptoms first. If they are asymptomatic, then look at location and size, and then, you can take a call on how you should advise this woman. So I think this question already answered that if you offer no treatment at present as an option, we would monitor her like maybe annually, or if it's somebody who's a little more anxious, then maybe every 6 months also is okay to do a scan or something. So let me come to Dr. Sarwan Kumar. What are the indications then to treat women who have fibroids? We've decided whom we are leaving alone. So when do you decide that, okay, this woman needs some help from our side because she's got fibroids?
Yeah, patients who have definite symptoms, especially those who are not keeping up with their hemoglobin, with heavy menstrual bleeding, and once we have started treating them with our conservative methods, majority of them may respond to our treatment, but there are still patients who are not responding to the thing, and they are becoming anemic again and again. Those are the sort of the patients who come to us regularly, especially middle-aged women who have these fibroids and come to us with symptoms of severe bleeding or dysmenorrhea. And sometimes patients who are diagnosed in fertility clinics. So if they have a type of fibroid which is there inside the cavity, and which we think that might be obstructing the implantation. So those are the patients who are supposed to have a look on doing some surgery for them.
Absolutely. So I think much has been said about being a quiet observer who can see the most without too much of interference with the natural processes. And the indications, as Dr. Sarvanakumar has said, is it has to be a symptomatic patient. The symptoms have to be troublesome to that particular woman, and those symptoms should be because of the fibroids. And then, of course, you look at the size, location, etc., and then decide whether these fibroids are an indication for treatment or not. So this woman then is concerned that whether hormonal pills, she's taking oral contraceptives. She's concerned that they will make the fibroid grow. Dr. Vani, then how do we counsel her? I mean, what do you tell her about this aspect?
Actually, she can be given oral contraceptives if required, so which will suppress the problems of menorrhagia, and she might be, if she is symptomatic, that will improve her symptoms free, and there will be no harm if she take it for a trial of 3 months or so. And we have to explain the side effects of OCPs as such, where she might experience mild headache or nostalgia or little bit weight gain. In that case, if it is convinced with her, then you can go ahead and then give a couple of months OCPs and try and see how she is, and then call her back after 3 months and see.
Yeah, I think what you've talked about is that they have a therapeutic role. But yes, of course, she is interested in the contraceptive aspect, and we can very well ask her that if you're comfortable with the pills, then you can continue. Because if we say, no, don't take the pills, she can land up with this kind of situation, isn't it, Dr. Vani? That she may become pregnant She doesn't want to continue because she's a single woman. And now she's come to at a 5-week pregnancy to you. What do you do? Can you use the usual medicated abortion technique? What do you expect?
I think if depending upon the size of the fibroid, you have to see the location of the fibroid and then decide what method would be feasible for her. I think so. She can go ahead with MTP if possible, depending upon the size and the position of the fibroid.
Yes, absolutely correct. And Dr. Jessie, let me come to you with this one. If one had to do a surgical procedure, surgical termination of pregnancy, she's 9 weeks, 6 centimeter fibroid. What preparations and precautions should the gynecologist keep in mind, and how should one proceed? Is Dr. Jessie with us? Not very sure. Yes,
Yeah.
she's with. Yes, we can hear you, ma'am.
Yeah. I think this is a difficult question for me to answer because personally I don't do termination of pregnancies.
Let's imagine that she has a 9-10 week sized pregnancy which is a miscarriage.
Okay, that's fine. So what basically we need to know is to be able to know where the site of the fibroid is. If it's just an intramural, we are not really, if it's just a subserosal or intramural, it's not going to really interfere with our management of termination of pregnancy. What I would worry is whether after this, if there has been a fibroid, which is like a type 3 or a type 2, where there would have been implantation problem, then when we try to empty the uterus, we may have preterm products of conception, which have to be removed carefully. So that's something which I need to keep in mind. So we cannot just put in a misoprostol and then say, okay, she's expelled. So I would like to make sure that I repeat a scan to see that the products of conception all come out. And one other thing is maybe she may have a little more bleeding than the others. So maybe able to cross-match and keep blood. And to, when you're putting in a misoprostol, keep her in the hospital and not send her home and ask her to come back later, as most often it's done. Maybe we'll have to admit her and keep her under close observation. And that's what I think of.
Yeah, I think that's a very practical way of looking at things. So, of course, we know that usually this type of a 6-7 centimeter fibroid may not necessarily be an indication to terminate the pregnancy. And in early gestational age, medicated abortion is preferred. The regime remains the same, but as Dr. Vani said, that depending on the location and the size, your success rates and outcomes may get affected. In case you have to do a surgical procedure, then have preparations in place, as Dr. Jessie said, that keep blood cross-matched, theater and anesthetist prepared. You can do some cervical priming with misoprostol, and then you can use ultrasound guidance to ensure that you've evacuated the uterine cavity. Excellent. So that's where we'll leave case 1 and we'll go to the next one. Here we've got a 36-year-old woman who has presented with heavy menstrual bleeding. She bleeds for 8 or 10 days every month with passage of large clots, and it's been worse since about 3-4 months. She's had 2 cesareans in the past, no other significant medical or surgical history. And the ultrasound shows a 4 centimeter intramural fibroid in the anterior wall. And the endometrium and the adnexate, they are normal. Her hemoglobin is 6 grams per deciliter. So this presents a little bit of a question as to how we should have the initial approach. Let me start with Dr. Jessie. How do you generally treat this severe anemia, which is associated with the fibroid-related heavy menstrual bleeding? And at what hemoglobin level are you comfortable operating on women?
No, we're not straight thinking about operating on this lady. We're just asking about treating severe anemia. At least in our institution, when it's below 6, we always give packed cells. Because, yes,
this one is just at the borderline, and she seems to be doing all right otherwise.
Yeah, you may, it depends on actually if she's been a little chronic and she's not an acute kind of a failure and things like that, and affordability of getting bloods and things like that, we may give anemia per se, maybe we can give parenteral iron and try to build up. Along with that, I have to look at to see how to stop this. If this bleeding is because of this fibroid, I don't think so, because you're saying it's just 4 centimeter. If I come back, isn't it, you said 4 centimeter intramural.
Yes, that's right.
So I'm thinking this cannot be the cause for the bleeding. Maybe some other cause may be there. Maybe she's got an inauguration, she's got depending on obesity and things like that, whether there's got to be some hyperplasia or things like that, because adnexia seems all right. Just a 4 centimeter intramural fibroid may not cause severe anemia. So I would like to see if there's anything else added to it, any other cause, and LCBC will tell me also whether it is just a loss of blood and anemia because of iron deficiency, or something else is also causing the problem.
Yes, I completely agree. The one aspect is to evaluate her completely, as you mentioned. See that there are no other reasons for the anemia. Look at any other associated problems causing the anemia, treat them too. And then replenish the iron, because most of the times the heavy menstrual bleeding results in an iron deficiency. You could do this parenterally. Excellent choices available today. For a select few, very severe anemia, clinically unstable, signs of failure, then you would admit her and give her blood packed cells, so on and so forth. So, Dr. Vani, very broadly, what kind of medical management are we looking at? I mean, what are the broad indications for treating fibroids medically?
You can first need to correct the anemia if she's anemic, sir. As Madam
so that's
said,
a very important indication for medical
management. And then to stop her bleeding, we can just go with tranexamic acid, tranostat in the dose of TDS for 3 to 5 days, and check out her bleeding status. And if she's not still controlled along with that, then you can give OCPs a trial, as we discussed in the earlier case.
Yes.
And or you can give her progesterone alone in the case of like medroxyprogesterone acetate.
Yes, this is also possible.
For
So plenty of choices for the control of the hemorrhage. And Dr. Sarvana Kumar, all these choices, there are so many choices related to only treating the fibroids. I mean, I'm not even talking about symptomatic management with progesterone or OC but there are drugs which are useful, or they've been claimed to be useful for treating fibroids. So what has been your experience with these drugs? So I'm specifically asking about GnRH analog, mifepristone.
Yeah, urlipristol acetate came, and it was a favorite of all those representatives. But at some point of time, that also went into some problems. It had problems with the liver, so that went out of. And again, they say that the tranexamic acid itself can cause some necrosis and autolysis of the fibroid and reduces the size of the fibroid. But still, we are not just for the control of bleeding we use, but for the reducing the size of the fibroid. Yes, especially if we think that the patient is deferring her surgery for 3 or 4 months, and she is very severely anemic. So probably we can give some GnRH analogs so that she don't much for the remaining part of her of the.
It's a reasonable choice in those circumstances. I agree.
And in RE486, again, they claim to be very good in reducing the size of fibroid, almost 50% they tell. But I have not personally used these drugs for them.
Thank you. So I think important inputs over there. What would be the reasons to manage medically to postpone the surgery? As the panelists have mentioned, if she's anemic, she's unfit for some reason, or some social economic factors are there, or for those where surgery is to be avoided, like if it's a repeat procedure, she's perimenopausal, 50 years and mild symptoms. And of course, ultimately, it's the patient's choice whether she would like to get operated or not. And these are all the various choices as far as medical treatment is concerned. You could classify them as to, their best applicability in terms of symptom management or managing the heavy menstrual bleeding. Some things like GnRH will cause a temporary shrinkage and give symptom control. Long-term ulipristal does give shrinkage and symptom control, but it has been associated with certain liver dysfunctions, and after 2018, in fact, it has been on the list for the European Union, and of course, mifepristone, letrozole are also there. So these are the various medical choices which are available. So now she comes to the clinic after 2 months of medical treatment and iron, etc. Her hemoglobin has gone up. It's 10 grams per deciliter. Damodar, let me ask you this. How do you advise her further? Is she a good candidate for conservative management? What do you feel?
So definitely she has bleeding, and she definitely requires some sort of management. Intramural 4 centimeters, yes, we can give conservative management, but how well does conservative management work is the question. Most of them, like you said, is probably to postpone surgery most of the time. If she's 4 centimeters, and the broad answer is yes. If she's a good candidate for conservative
Damodar,
management,
your
yes.
audio is not
Yeah,
clear.
something's gone.
Sorry. Maybe the could somebody else take it? Internet connection. Hello.
Yes.
Yes, better now.
Yeah. We can try conservative management, and if it works, it's good. If conservative management works for her, but most of the time, when somebody has so much of bleeding, it may not work. So first, we give conservative management. If it works well, yes, continue it. Only thing is, what conservative management will you give her? I mean, what are the drugs available right now?
Yeah, we'll come to that. We'll come to that.
Yeah.
I'm just coming to that one. So, say this woman is not really for any major surgical procedure, but there is one more option, Dr. Victoria, that we have, and
Yes,
that is
sir.
inserting a LNG IUS. So, any experience with using LNG IUS in women with fibroids? How do you select them? And
So she's quite a good candidate, sir, because she has had the previous 2 sections. She may like to avoid surgery, and the uterine size is probably less than 12 week size. So that is also an ideal condition where you can use LNG IUS. Only thing, there is a possibility of expulsion with the fibroids. You have to counsel her about that also. But if she wants a conservative management, we can go ahead with an LNG insertion, sir.
Yes, I think that's nicely summed
That
up.
will give a very good symptom relief will be there.
Yes, and if it's a moderate sized one like this,
4
and
centimeters.
if it's not indenting the cavity, especially, then
non-cavity
all right,
starting, we can do it.
Okay, so let's imagine that she's now 36, previous 2 C-sections, family's complete. She fails medical treatment, it's not worked. We put in an LNG, but she threw it out. Again, got an episode of menorrhagia. She needs surgery. So, Dr. Vanita, what type of surgery? Which route of surgery? What is your opinion?
36 years. I wouldn't consider a hysterectomy on her, sir. I would initially counsel her only for a myomectomy. I would definitely explain the pros and cons to her. I would counsel her saying that myomectomy is a more conservative surgery, and I would also tell her myomectomy would definitely get her rid of her symptoms for now. But if she is very inclined on the fact that she does not want to keep coming for further follow-ups, or she's just fed up and she wants to get rid of it because she's already had 2 surgeries, and she comes up with hysterectomy and she's very firm on the ground that she wants only a hysterectomy, that's the only place where I would choose hysterectomy. But my choice would only be a myomectomy for her, sir. With regard to route of surgery, I would prefer a laparoscopic approach, sir.
Okay, so I think
anterior wall 4 centimeter.
It should be all right with the laparoscopy. There aren't too many concerns about the scar, etc., because she's not probably going to have another event where the uterus expands. So I think we should be fine with that. So of course, I mean, we have to individualize and counsel. Well, one shouldn't always presume that families are complete, because even though sometimes 38, 40, but they may be like, okay, maybe I want one more, can't say. Whether you do a hysterectomy versus a myomectomy depends on the age, clinical features of the fibroid, And then, of course, the route of surgery depends on the technical factors and the surgical experience. Absolutely. So let's come to case 3, where we have a 48-year-old woman. She comes to the casualty, acute urinary retention. The RMO has catheterized her and notes that there's a large mass which is arising from the pelvis. A quick ultrasound shows a 28 centimeter cervical fibroid and an otherwise normal abdomen and pelvis. So that's what the clinical picture looked like. And this is not an ultrasound, it's an MRI, but you can see that huge mass which is occupying almost all the space which is there in the pelvis. So, the first question, because it's an emergency, Dr. Vanita, for us, the decision is very simple. Well, the urinary retention is because of the fibroid. Fibroid needs to come out. And that's what one would kind of tend to tell the patient and the relatives. But they are not keen to have any surgery done. Is there any role for medical management in these situations?
No role.
Definitely not for a 28 centimeter fibroid, which is symptomatic by causing acute urinary retention, sir. She is not a candidate for conservative management, sir. We need to sit across the... Huh?
Yeah, not a candidate.
We need to sit across, explain to her the risk factors. This is not going to be a one-time episode. She can always have recurrence of retention, and we need to counsel her with regard to the risk of surgery, the ureteric injuries, and how we need to take care of them with stent and all that. A detailed counseling should be done to the patient.
The next question to what specific risk? I mean, we always consent our patients that, okay, we are going to give you anesthesia and there can be this and that, but specifically for her, what are we keeping in mind?
Specifically for her, I would definitely talk to her about the risk of ureteric injury, sir, and also maybe because of the size, if morcellation is difficult, and or if there is no space to deal with it, a laparoscopy may need to be converted to laparotomy in very, very difficult situations where there was no space at all to manipulate the uterus inside. So I would definitely go ahead with laparoscopy with a concern explaining that a laparotomy also could be
right
made.
So we have to talk about risk of organ injury, of bleeding. I think I would talk to her about that too, because it's a huge mass.
Yes.
Once in a while you can have problems, and then conversion of a root especially. These are the important specific aspects. So Dr. Victoria, yes, she understands now that she needs a surgery, and she agrees that, okay, I'm 48, so it's all right. You can go ahead, do the hysterectomy. But she wants to attend a wedding next week, and she's got this catheter in place. What do you do? Let her go, or remove the catheter and see what happens? How would you manage?
I think most probably the compression effect will be there, sir. Even if you remove the catheter, she'll continue to have the retention. Or probably we can try a shot of GnRH agonist if she's so keen on having it removed. We'll see whether the volume comes down, but I don't know whether this will have an effect within a week's time to reduce the volume of the fibroid. But I think most probably she'll have to go with the catheter.
Yeah, she can wear it inside the sari.
Yeah.
So she'll have to manage somehow. I would rather not take the catheter out, because it will just lead to another episode, another catheterization. You increase the risk of a urinary tract infection, so on and so forth. So Damodar, I know you love laparoscopy, but this is a spot where it's a huge fibroid, 28 centimeters. What route would you personally select? I mean, would you go for a laparoscopy, or just tell them that this is going to be easier to do it laparotomy?
I always will tell them, yes, put in a scope first and see if it's feasible.
Okay.
But this is huge. It's very, very low threshold for laparotomy.
I agree with that completely. And you've got to take that call, based on what the expectations of the woman are. So that's a diplomatic answer. You think about laparoscopy, but have a low threshold for going in for an open surgery. No,
definitely,
there's no shame in doing
it's huge.
that.
This is really huge.
Yeah, it's an exceptionally big one. I mean, that's the size which would be needed to cause that kind of pelvic compression and give the urinary retention. So you do see once in a while, those kind of situations. What would you do, Damodar, to reduce the risk of bleeding? You know, that's one aspect that we are worried about.
Yeah. One is probably a uterine artery ligation at the origin.
Okay.
If it allows us to do it. The sheer size might not allow us to go to into the lateral spaces at all.
Yeah.
Then probably you have to just use your vasopressin. And if possible, if you're doing a laparotomy, then you can probably put a I mean that's tourniquet. If that, yes, that's the main thing. Yes.
Right. So
devascularize one by one. All the ligaments, the IP ligament, and all this. So again, the blood supply is reduced.
Yes.
And
that's probably the key, because if you isolate the vascular supply, then you're going to be in a much better position in terms of the bleeding. So I agree with that. See what you can do in terms of the lateral pelvic wall, and then come in and see that you
I would say
devascularize
definitely
the
start
fibroid.
with the IP ligament, so that you can even isolate the ureter at the same time, and then proceed.
Yes, Dr. Sarvana Kumar, one risk that we spoke about is, the ureter. So in these kind of situations where it's like a high risk situation, any pre-operative or intraoperative measures which you would like to take to avoid this damage from happening?
Pre-operative, probably if we have, if we can track the ureter either by an IVP or a pre-operative stenting, that would be better. But one of the better operative techniques is where this whole tumor is there and the uterus sits on the tumor, perched upon the tumor. Then you have to probably go for a skeletalization of the uterine artery. And if we are probably the dissecting of the bladder anteriorly, that will pull down the ureterus to some extent. And once we clamp the uterine artery, skeletonized, then we can neatly take out, dissect off the uterine artery from the surface of the tumor. That probably will take down the ureterus also along with it when we are doing a surgery.
I agree with you completely. It's important to locate the ureter in these kind of situations. And
and if I may, sometimes you might even have to maybe just do a myomectomy first, and then
proceed with a hysterectomy.
Absolutely, because if it's occupying the whole
that is
pelvis,
very helpful.
You might not be able to deliver the specimen out of the abdomen, even if you're doing a laparotomy. And that's what we ended up doing. We did a laparotomy. It was actually 2 fibroids, and you can see the right adnexa is where most of the bulk is. It was lifted right up, and that's the vascular bundle right in front, where the urinary reflection was. So here you can see, this is the point that Dr. Sarvana Kumar was also trying to make, is that the ureter might actually be lifted quite high up, and you need to make sure that you are able to push that away, localize it, and then clamp the IP ligament. And then once you mobilize it, then it will fall down, to its usual position on the lateral pelvic wall and towards the pelvic floor. And then you're all right. Then your risk level really reduces drastically. So let's just look at some quick alternate scenarios. And the first one, of course, we spoke about that if it's, occupying the whole pelvis, you might want to actually do a bit of myomectomy or debulk it and then remove it. Dr. Vani, what would you do if this fibroid belonged to a 22-year-old girl? I mean, important tips for a myomectomy, very difficult situation.
First of all, we should know her marital status, and if she's bothered about her symptoms, we have to ask her symptoms. And
so she's 22.
No, 22 years, symptomatic. We have to ask her the first her presentations like symptomatic, or whether she's planning to get married, and how big is the size of a fibroid. What is the location of the fibroid?
Yes, it's a 22-year-old girl who's come to the casualty, acute urinary retention, the same fibroid, 28 centimeters. So you need to do something. I mean, there's no way that we are going to leave her alone. So what do? We need to do the myomectomy.
Yes, we have to proceed.
Some tips which you would like to share. Damodar spoke about a couple of important things, that You could think about ligating the uterine arteries at the origin.
Uterine artery at the origin.
Yes. But I think what I would do is again try to define the anatomy in the same way. I mean, make sure that the ureters are away and then go ahead and do the myomectomy. There'll be a huge dead space which we need to close, of course. And let's go to Dr. Jesse. What features in a large uterine fibroid would make you suspect a malignancy? And in case you came across this kind of a situation on the table, what would you do?
Basically, the capsule may not be well defined in a usual benign leiomyoma, and then when you cut also once you cut the capsule, the bulge is not there, and it may be quite vascular. Sometimes it is like you find an yellowish kind of a degeneration that is there. So this will tell you it's not a simple degeneration and it's a large fibroid. What I would do is, because it's in a big setup, we would ask for a gynae-oncologist to come and see. Otherwise, what we will do is, doing a frozen is not actually very well defended when it comes to ruling out a malignancy like a sarcoma via frozen. So we may, we are talking about this 48-year-old lady, or we are?
Yes.
Then maybe I would go ahead with do a BSO as well, and maybe call my gynae-oncologist to check to see whether there's anything there, whether they would not want to do anything further.
Right, absolutely. I think it's the suspicion which is important, and then you try to stage it to whatever extent that one can, given the circumstances and the clinical situation in which one is operating, and then take it from there in terms of what pathology you've come across. So we know that fibroids can come in all shapes and sizes, and they can belong to women at various stages of their reproductive careers and their lives. We need to individualize. We need to really select and be careful in terms of what type of treatments that we are offering. But often fibroids are a great opportunity to be a good obstetrician, because ultimately obstare, to observe. That's the key element in treating fibroids, according to me. So with that, I'll close the panel with thanks to the panelists. You've been brilliant, absolutely spot on with the responses, and thanks again to the office bearers for the invitation.
Thank you, sir.
Thank you, sir.
Lovely moderation.
Thank you, sir.
Thank you, sir. I would like to thank Dr. Prachit and all the panelists, Dr. Vanita, Dr. Victoria, Dr. Damodar, Dr. Sarvanakumar, Dr. Bani, and Professor Jesse. Thank you, everybody. It was excellent.
It was very interesting.
Yes.
Fantastic. Dr. Atul, sir, still he is there. Do you want to give any comments, sir? Atul Munshi, sir? Okay, he was there. I saw his name. No problem. We'll proceed. Ashri?
Yes. Now I would like to invite Dr. Sarvanakumar to give the vote of thanks.
1 minute, praise. It was the panel discussion was fantastic. Now we will go to the results of the second session and the question for the third session. Chitrakala, can you post it?
Yes, ma'am.
Dashri, you can read.
Yeah. Choice of treatment with correction of anemia for 34-year-old lady with previous cesarean with 4 centimeter fibroid, 8 gram hemoglobin. The ideal treatment is OC pills, ulipristal acetate, LNG-IUS, mifepristone.
Ashi ma'am, I'm not able to answer.
You cannot answer.
It is not for you.
Cannot answer. Only for delegates.
Okay, ma'am. First question I could answer. Second second and third I couldn't answer.
Normally, it is not for faculties, Vanita.
Okay, ma'am.
Yes, Chitrakala, you can post that answer for our second session. So the second session question was effect of fibroid on pregnancy except miscarriage, preterm labor, PPH and macrosomia. Answer was macrosomia. The answer first who gave is Dr. Priyanka Sudimuthu from Tanjavur. Priyanka, congrats. So first session, Dr. Nandini Raman from Chennai. Second is Priyanka from Tanjavur. Now, once again, I thank everyone, whoever has participated as faculty and delegates. Rajshri, you can invite Dr. Saravana Kumar for a vote of thanks.
Yeah. Before I invite Dr. Saravana Kumar, I would like to thank TNFOG, Dr. Sampath Kumari and Dr. Anjalakshi Madam for giving me this opportunity. Now I invite Dr. Saravana Kumar, please, to give the vote of thanks.
Madam,
After
you
the
have
vote
made...
of thanks, the third session winner will be posted. Okay, Saravana Kumar.
Rajshri Madam, you have made my job very, very easy, because after each session, you gave a mini vote of thanks for each of the participants. Thank you. So at the outset, I would like to thank TNFOG for selecting a topic which we encounter commonly in our practice, a much needed discussion for the general gynecologist. And at the same time, it is also encountered by all those subspecialties also, especially this infertility specialist, endoscopist, also obstetrician, who rarely encounters a fibroid with a pregnancy. So I thank the president of TNFOG, Dr. Anjalakshi Madam, Secretary Dr. Sampath Kumari Madam, who tirelessly organize CME after CME every week, and almost 10 to 15 CMEs in a month and various topics, and who keep the flock of Tamil Nadu societies within their wings. I would thank our chief guest, Dr. Atul sir, for his address, and who remembers the hospitality given in Tamil Nadu. At the same time, I thank the Yuva speakers, Dr. Divya Ranjit and Dr. Niranjana Ashokan, who were crisp and to the point, and also elaborated on all the aspects of their speech. And also I thank Dr. Nidhi Sharma and Dr. Vijayalakshmi Madam for being judged for that session. I'll also extend my thanks to Dr. Selvapriya Saravanan, Dr. Subhash Malya, and Dr. Vijayalakshmi Shashadri, who gave an excellent talk about all those things. It's almost like it was like I was a student listening to all those lectures from all the esteemed faculties. They covered all aspects of fibroids as well as the gray areas also. And I would also thank the chairpersons for the session, Dr. Tamil Selvi, Dr. Saraswati Madam, and Anuradha Madam. And this was a very wonderful panel. We had a very, popular faculty for our TNFOG today, Dr. Parikshit sir, and he made the panel very, very, very comfortable for all of us. So he encouraged us to come out with the answers, and also he made us feel that we are also very prominent and answering to whatever he has asked. And also I thank the panelists, Dr. Vanita, Dr. Victoria, Damodar, Vani Madam, and Jessie Madam. And at last, I want to thank Shield Pharma also, and also Mrs. Chitrakala. She made a wonderful thing when we did a New Year conference. So thank you all. Thank you for me.
Saravana Kumar, Rajshri, coordinator.
Rajshri, okay, madam. Rajshri, madam. She was our coordinator from the start, and she helped me a lot in making this thing. Thank you,
Thank you so much.
Thank you.
Help பண்ணவங்கள மறக்கூடாது Saravana Kumar. Thank you. Anyway, I thank everyone. Now we will see the results of our third session. Thank you, Saravana Kumar.
Thank you.
Dr. Chitrakala, ready ஆயிச்சா? Yes, the winner of the third question. What was the question? The choice of treatment for 4 centimeter fibroid with hemoglobin 8 gram, 34 years with correction of anemia. The ideal treatment, mifepristone, ocipril, celiprestol, and LNJIUS. LNJIUS is the answer. that was given first by Dr. Jayasudha Ratnam from Puducherry. Most of the delegates would have answered, but whoever has the results has come first, that will be considered as winner. So Dr. Nandini Raman, Dr. Priyanka, Dr. Jayasudha Ratnam, congrats. Thank you. Chitrakala? So first we were giving that BP apparatus and pulse oximeter and BP apparatus. I don't know this time what they are going to give. I will inquire from the Shield people and will inform to the concerned people. We have the phone numbers of the winners. So the prize will come to your house from Shield Pharma people. Okay. Chitrakala, thank you very much, and all the TNFOG members, EC members, delegates, everyone. Thank you.
Thank you. Thank you. Thank you.
Thank you.
Thank you.
So, I will have an announcement. From tomorrow, we have the paramedical CME, paramedical training of the paramedicals on safe motherhood. From tomorrow, 1 week, 4:30 to 6. So all of you ask your nursing home owners, please send your sisters, paramedical staff nurses, VHN, whoever to participate in the program. On 19th, 2:30, normally we have a CME on 3rd Saturday. Since this 3rd Saturday, we have some Onam and Foxy webinar is there. We are preponing to 19th, 2:30 to 6, CME on oncology. We have combined with Foxy Oncology Committee. I request everyone to join in that webinar. Today, we have around 502 registrations. Really, I thank everyone for the good response. Thank you, Madam. Anjalakshmi, Madam.
Thank you, Sambat. Thank you.
Thank you. Thank you, Maharaj.
Thank you. Thank you. Thank you.
Yes.
Thank you. Thank you, Sambat, madam.
Thank you,
Hello.
Victoria, and all panelists. Thank you so much.
Hello. Hello.
Hello.
Madam.
Yes, madam.
Hello.
Yeah.
Correct.